अटैच करने के लिए ये करना पड़ेगा। मैं कर लूँगा पर कोई प्रॉब्लम नहीं है।
सर की इंट्रोडक्शन होगी जब चेयरपर्सन इंट्रोड्यूस करेंगे सर को, तब आप सर का लैपटॉप अटैच करेंगे। ठीक है, अभी ये वाला सर का लैपटॉप इधर रख लेते हैं ताकि
मैं हटा देता हूँ इसमें से।
नहीं सर, और आराम से यहीं रख लेते हैं ताकि डेलीकेट से बस ये इधर ही रख लेते हैं, यहाँ ये जो रख लेते हैं, क्योंकि ये अलग अलग नाम बोलती रहेगा फिर बहुत ही गड़बड़ हो जाएगी। First one here. Sir. पीछे जाना पड़ेगा, चेयरपर्सन कैनॉट सिट देयर, नजर नहीं आएगा। बड़ा मुश्किल है, जैसे नॉर्मली जैसे घुमाओ ये उस साइड कर देते ना, एक्चुअली ये भी नीचे रखे होते हैं, इसका बैनर भी नीचे होता है। बैनर की नीचे होता है, ऐसा आगे कर देते हैं ना। भारतीय लोग ने बैनर देख के वहाँ चेक किया कि आपको कितना जरूरी है। नीचे कितने ना चेयर पे इन पे हाथ नीचे नहीं तो उसको कैसे लगा देना बैनर आते हैं, तो बैनर को लगा दो और मैं ऐसे लगा देती हूं बैनर को, इस तरह बैनर को ऐसे कर दो, थोड़ा पीछे ले जाके टेढ़ा कर देते हैं ना, और वो डेस्क पर मूव कर देता है। पीछे भी कर सकते हैं, इसको डेस्क को मूव कर लेते हैं। अब इसे बात कीजिए है वहां चेयर सेट पे देखो भी पूरी स्क्रीन दिख रही है, आगे तो इसको भी जगह दीजिए। आप इस पैशन में काम को पीछे की तरफ वहां से पूरी स्क्रीन दिख रही है। लाइव होता हाँ वी आर लाइव लिंक चेक करिए अपनी डिस्प्ले लगेगा 5 मिनट्स में आएगा 5 मिनट में हम जब शुरू करेंगे तो 12 बजे ओपन हो जाएगा, तो इसलिए हम चेक कर रहे हैं तो राइट से वो आएगा जब लाइक मैंने काफी सारा शेयर तो कर दिया अभी व्यू 7 वाचिंग 7 में क्या भी आएगा आएगा मैम वो दिख रहा होगा ना, लाइव हमारा फर्स्ट इमेज दिख रहा है ना, उसी को लाइक कर देंगे। ये आ गया ना, लाइक हो गया है। और यहाँ से नहीं करेंगे program under the aegis of Obstetrics and Gynecology Society of Northern India. Now I request Dr. Vanita Suri, Professor and Head, Department of Obstetrics and Gynecology, PGI Chandigarh, and the organizing chairperson of this event to introduce us all to the workshops that are scheduled for today. Ma'am, please.
Thank you, Mac. Dear friends and students, I wish you all a very good afternoon. On behalf of Obstetrics and Gynae Societies of Northern India and PGI, I welcome you all to this annual meeting and CME under the aegis of FOGSI. First of all, I would like to congratulate you to have survived COVID and hope to do so in future too. Thanks to the Almighty, to our body immunity and healthcare services. Like always, this time also, we have organized two workshops. The first one is research methodology, simplified for clinicians, and the second is safe clinical practice. We all remember entering chemistry lab for the first time in 9th class and getting introduced to experiments. That was our introduction to research for the first time. Research and good research is essential for a scientist, whether in medicine or other areas, for the advancement of knowledge, and more so for surviving in this competitive world. For students, thesis writing is must, and for seniors, the whole academic life is dependent on good research. Kabir has rightly said, Guru bin gyan na hoi, and we need to learn from the learned ones. For this workshop, we are blessed to have stars of the research world who are going to teach us the right process of research in order to get the right results. The speakers have in-depth knowledge of the subject and have received special training in this field. The chairpersons are the part of our thesis committee and ethics committees and are from different departments of PGIMER. They have analytical minds and an eye for detail. I'm grateful to all of you and welcome you all to this workshop. The second workshop is on patient safety. Traffic discipline is important for preventing accidents. Similarly, healthcare discipline is vital for preventing medical accidents. Any error on the part of doctor can lead to lifelong regrets. A patient may lose life, but the doctor loses living. And there is collateral damage too. The guilt trip can lead to many casualties. According to Atul Gawande, I'm sure all of you must have read, the famous writer of books like Checklist and Better, no field is as complex as medicine because here the lives are on the line with every decision. Our faculty has done a lot of hard work for arranging this workshop, and many faculty members from other departments are going to be part of this workshop. I want to express my gratitude to all of them. I'm sure the participants will be enriched with mental skills to deal better by the end of these workshops. I once again welcome each one of you to this forum. Thank you and happy learning.
So now we'll be beginning with the first session for the day. I would like to take the opportunity to introduce our three esteemed chairpersons for this session. First, I would like to introduce Dr. Surinder Rana, who is currently working as Professor and Head in the Department of Gastroenterology for Unit 3 in Postgraduate Institute of Medical Education and Research. He has got humongous research in the areas of pancreatic diseases, endoscopic ultrasound and innovative endoscopy, and is a member of various task forces of different scientific societies. He is the Associate Editor of Digestive Diseases Sciences and the Section Editor of Annals of Gastroenterology. He is the Editor of Journal of Digestive Endoscopy and has published a number of research publications in his name in various national as well as international journals in the field of pancreatology. Our second chairperson is Dr. Nusrat. She is Professor Clinical Pharmacology Unit in the Department of Pharmacology, PGI Chandigarh, Member Secretary Institute Ethics Committee for Drug Trials. She has over 2 decades of experience in bench-to-bedside research and providing training for the same. She is the founder member of the Consortium for Dose Optimization. And the third chairperson for this session is Dr. Kamal Kishore. He is Assistant Professor in the Department of Biostatistics in PGI Chandigarh, currently working in 10 intra as well as extramural projects funded by PGIMER, ICMR and UNICEF, and has published more than 40 articles in peer-reviewed national as well as international journals. He initiated the concept of biostatistics clinics and conceptualized and delivered talks on Saturday Statistics Cafe. His interest and mission is to make everyone data literate. Now I request Dr. Surinder to please introduce the first speaker of this session. To please come to the podium and introduce the speaker of the session.
I request all chairpersons to please take the, sir. Dr. Kamal, please. Dr. Surinder sir will please introduce our first speaker for today.
Thank you so much. At the outset, I would like to thank on behalf of my co-chairs, Ma'am Vinita Suri and the department and the organizing committee for inviting us to this workshop and make us also learn. We are also going to learn a lot of things here. And without wasting time, I would invite Professor Deepak Chawla who is a professor of neonatology at GMCH, Chandigarh. He is a section editor for neonatology, and his areas of interest are research methods, systematic reviews, guidelines, and quality improvement. And he's going to talk about what to study. So he's going to talk about tips for the students to how to pick up a thesis topic and look at the feasibility as well as novelty, both in combination. And Deepak, we have been meeting together at GMCH and technical committees. So here we are now meeting in a research meeting.
Thank you, sir. Thank you. Thank you to the Department of Obstetric Gynecology, PGI, for giving me this opportunity. I just had a talk with Dr. Usha Datta. When Dr. Ashima told me that we're going to organize, I said, please discuss with Dr. Usha Datta, and whatever program she finalizes, I'm fine with it. Research methodology, typically, Dr. Usha Datta and Dr. Swarov organize many research methodology workshops in PGI. And usually it is done over 3-4 days, at least 2.5 days. So compressing it in 2 hours, I thought Dr. Usha Datta can take the best call that how to compress it in 2 hours. And she has wisely selected 4 talks: what to study, how to interpret, and then how to publish. So to make a beginning, so this first 30 minutes, we'll try to look in a simplified manner, what to study. While we look at this particular question, what to study, I think one very important thing is to begin with end in mind. That if you want to do a study, especially I'm trying to focus this talk on postgraduates or students who want to initiate their study. So what is the end point of doing the study? Why do you want us to do a study? There can be different reasons. Of course, the first is what is published in the cover of the thesis, partial fulfillment to achieve the degree of obstetric gynecology. This is the basic minimum and requirement. And if you have an end higher than that, maybe you want to publish it somewhere, or you want to do a trial or a experimental study which can change the practice. You want to do a study which is powered enough to change the practice, or which becomes part of the systematic review so that it contributes to change in practice, clinical practice, a new drug or new device, new way of managing patients. Or you want to do a big study, maybe field trial, large study, which can become part of the policy program, maybe new vaccine, cervical cancer vaccine, new way to manage PPH. Or you want to do such big study that which will entirely change the paradigm of the way your specialty is practiced. So there can be different endpoints, and of course the one endpoint which all of the students will start with is to at least get your degree. But I think with awareness of publication and requirements of publication by very institute bodies or by medical council, most of the PGs now try to publish. So I think starting from publish, depending upon what kind of research you want to do, you may be able to change practice or may be able to contribute to policy and change. But whatever you want to do, you should have end in mind. The type of question you choose will determine whether it will get published or not. As we will see, some questions, even if you answer in best possible way, employing a good study design, but if the question is not correct, it may not be published. So you have to think from the beginning what you want to answer. So what is research question? The research question is essentially what is purpose of the study, what you want to look at, what specific uncertainty you want to resolve by answering that question, or what issue you are going to resolve, or if study is successful, what answer it will provide. So the same thing saying in different ways. So research question is an articulation of these questions in scientific terms, starting with a broad research idea and then specifying your research question. So imagine we have a senior guide, and every 6 months new PGs come in PGI. So you get four students. Now, how do you select the research topic or thesis topic? What are different ways by which thesis topic are selected? So well, let me take some examples. So maybe the guide will say to one student, go to library, look at journals, find a topic. Does it happen? No? Okay. Second way can be taking rounds or your perinatal mortality meet or section audit or academic activities in which we say that these kind of patients we don't know, there's a lot of variation, outcome is not good. So let's study this. So that becomes a starting point. Third way can be or your guide has come back from an international conference, has been exposed to a lot of papers, and that particular conference consciously or unconsciously drives the research question. You say that, let's look at this particular question. Fourth can be you discuss in a journal club, an article is being discussed, you find that there are many limitations to that article, and you think that the question can be answered in a better way, in a better study design, and that becomes the starting point. Then leaving apart all this, guide may say, I have an innovative idea, let's study this. Or not for a student, but for a faculty, mid-level faculty or junior faculty, maybe he or she has looked at ICMR or Bill and Melinda Gates Foundation or WHO's research priorities, or a call for proposal, and from there you find that this particular call for proposal is there, let's look at this particular topic, and the question arises from there. Or you say that already big studies published in a journal, NEGM, Lancet, Obstetrics Gynecology, Green Journal, a big study is published, but you say that this study is applicable only to high-income countries, or patients are different, or baseline variables are different, and we want to replicate this study in our population, so replication type of study. So these are different ways by which a question can arise. And I have also seen the people looking at a type of go to NML, PGIMER library, find a good topic, and we will copy it. So this also happens very commonly. So these are different ways by which the starting point of research idea comes. So once you have that research idea from observations, clinical observations, reading literature, looking at limitations of published literature, looking at any difficulties or shortcomings in whether looking at the way studies conducted, internal validity, or the way it is applied to our population, that external validity, from where you get idea, or from conferences, research priorities, call for proposals. So research idea will come from there. And from there, one will try to frame a research question from research idea. That is what we will try to do. And from there, you will have your objective. From objectives, outcome variables will flow. And from type of question, objectives, variables, your study design will come and sample size will come. So research idea is the beginning of the process, of the journey of research. Now, once you have a broad research idea in mind, it needs to be refined and filtered. So it is always a good idea to begin with 5-6 different research ideas. Although it is not easy when you are getting a PG, 3 or 4 PGs per guide every 6 months. Sometimes it may become difficult how to find a new research topic. But ideally speaking, when a PG student or student is looking at doing a thesis, begin with 3, 4, 5 research ideas and then try to refine and filter them by different ways. And we will look at 2 different ways. You must be aware of these acronyms, PICOTIS and FINER, which are used to look at the research ideas. So these are expanded. PICOTIS is expanded as population, intervention or exposure, comparison group, outcomes, time frame, effect size, and study design, while FINER is expanded as feasible, interesting, novel, ethical, and relevant. Now, let's take an example, and pardon me if this research question is not one which needs to be answered, but from whatever knowledge I have of statistics. So let's look at this research idea. So this is just research idea. Does calcium supplementation in preconceptional period and during first trimester decrease the risk of gestational hypertension or pregnancy-induced hypertension? Let's say this is this is the idea I got from a book or from an article. Now, once you have this idea, the next thing is to, as I said, refine it. And the first element in refining is looking at population. So which is, how will you describe the population in which you will try to answer this question? How will you define the disease or condition if the population is to be defined? How will you define pregnancy? How will you define preconceptional period? In what setting you will do this study? You want to do this study as a community trial, randomizing pregnant women enrolled in a CSC or PSC or subcenter, or you want to do in a hospital setting in women who already have history of pregnancy-induced hypertension in previous pregnancy? And which type of participant you will like to exclude? Maybe participants who are at a very high risk of PAH, like maybe age more than 35 years or less than 18 years, or essential hypertension. Do you want to exclude these patients? So once you have a research idea, so first try to refine the population. And once you have refined the population, then you can say that, let's say, women in age group 18 to 35 years who are planning to become pregnant in next 3 months and do not have essential hypertension, no essential hypertension. So we started with a very broad idea, can calcium prevent PIH, and then try to look at in which population are you looking at. So let's take an example of 18 to 35 years, planning to become pregnant in next 3 months and no essential hypertension. The next thing, intervention or exposure. Intervention is when you are doing an experimental study, enrolling patients and assigning them to receive intervention. Exposure when you are doing a cohort study or case control study or observational study in which you are not intervening, so you're defining it as an exposure. So here calcium is an exposure. So calcium can be intervention if you're doing experimental study. It can be exposure if you're looking at spontaneous intake or voluntary intake of calcium. So let's try to look at it as an intervention. So calcium, if you're trying to give calcium, you will be giving calcium as a extra milk, 1 kg milk every day, or dairy product, or you want to give as a 500 mg tablet, or as a 750 or 1000 milligram tablet. Will it be calcium phosphorus, calcium carbonate? Will that tablet also have vitamin D? Okay, so that need to be defined. So what preparation, what route, orally, what dose, once every day, frequency 500 mg BD, OD, weekly, you have to define. And then any variation in dose which can be there. And very important, not for this particular study, but sometime we are looking at complex interventions. For example, your next workshop is on patient safety. So patient safety may have behavioral interventions, may have training of people, may have doing workshops, conducting, having checklists. So if you're doing a complex sort of intervention to change practice, then even that needs to be defined. So the intervention can be as simple as taking a drug, or as complex as including many behavioral or training interventions. So whatever intervention you're thinking of, here you need to define that particular intervention. So let's say our intervention is 500 mg of calcium every day orally. Okay, so let's say this is our intervention. Then what is your comparison group? In comparison group, are you comparing with another active drug, or you are comparing with placebo, or you comparing with, let's say, a standard treatment? Okay, so for example, if you're enrolling women 3 months before they plan to become pregnant, in control group, what will you give? So will you give a placebo tablet which do not have any calcium, or you want to give folic acid? It may confound the effect on hypertension, or you want to just give standard guidelines on dietary therapy. If mother is anemic, we want to treat anemia in them. So define your comparison group, what you want to do in comparison group, giving placebo or no drug. But one important thing is standard treatment should not be withheld. So ethically, you cannot withhold a standard treatment from comparison group. If standard treatment is already there, if let's say folic acid is recommended in preconceptional period, then it has to be given to both the groups. So define your comparison group. So let's say we want to give placebo tablets which do not contain calcium to the comparison group. Then next is outcomes. Outcomes can be of different types. Outcomes can be health outcomes, which are clinical outcomes. They can be surrogate outcomes. For example, most important outcome is survival or death, which is counterpart of the survival. So mortality, want you to look at mortality, you want to look at clinical events. For example, if you want to look at pregnancy-induced hypertension, so how will you define pregnancy-induced hypertension? You will define it in a standard manner, 140/90 twice, BP taken 30 minutes apart with proteinuria 1 plus at least. So want to define in that manner. At what gestation it will be defined. So define your clinical outcome, whatever you want to do. Then how, if you're looking at patient-reported outcomes, how will you define them? If you're looking at severe PIH, how will you define headache? How will you define blurring of vision? So define all your outcomes, look at all candidate outcomes, define those. It is always a good idea that if you're doing a drug trial or experimental trial, also look at adverse events. There may be, if you're giving calcium, maybe some of them others will have some GI effects. So that will become your outcome. Then there can be other outcome depending upon the setting, like economic evaluation, burden in setting. Sometimes there can be surrogate outcome, which are not outcomes which are clinically meaningful for patient, but they may have clinical meaningfulness for clinicians. Many times these are needed for thesis topics because you do not have time frame to look at clinical outcome. You don't have sample size to look at clinical outcomes. For example, there may be serological markers of pregnancy-induced hypertension, maybe ultrasound markers, blood flow markers. They may become outcomes. So once you list the outcomes, one of these will become your primary outcome. So that primary outcome will determine, will become part of the research question. That particular outcome will come in your PICOTUS. The same outcome will come in your sample size calculation. And other outcome become your secondary outcomes. Now there are various pathways to select which outcome you want to choose, depending upon the time frame you have, importance of outcomes, and standardized outcome listing for particular specialty. So choose particular outcome and look at, it is important to look at both good outcomes and bad outcome. Means it is important to also look at adverse outcome, as I said earlier. Now, if outcomes, you are looking at outcome, one very important thing is to try to choose objective outcome which are objective and which are defined in a standard manner. Don't try to define PIH or gestational hypertension in a new way for your own study. Try to follow a standardized definition for your outcomes. And then very important to look at time frame of the outcome. So these outcomes and time frame will determine your PICOTUS element. So outcome in this particular can be adverse pregnancy outcome. It can be stillbirth or neonatal death, or it can be just development of pregnancy-induced hypertension, or it can be incidence of severe preeclampsia. So depending upon what you choose, this will become your outcome. And time frame is not time frame of study. It is not study will be conducted over 18 months or 12 months. The time frame is what is time frame for development of outcome in relation to your patients. So time frame for this particular will be end of pregnancy. If you're taking severe preeclampsia, so time frame will be maximum, let's say 9 months or 40 weeks or 44 weeks, whatever time frame you want. Then next element in PICOTUS is effect size. Effect size is how much reduction in the outcome you are expecting. So what is incidence of severe preeclampsia in the population you have selected? Let's say it is 10%. What is effect of your intervention? How much calcium intake will reduce it? So will it bring down from 10% to 7%, 5%, 3%? So this particular 10% you will come to know from previous studies, publications, textbooks, systematic reviews. And how much reduction? Again, you will have an idea from previous studies, animal experiments. I'm not going to do detail of that, but this idea you will need to get depending upon the topic you have chosen, and this will then determine what sample size you will need to conduct the study. So let's say effect size is reduction from 10% to 7%. And then finally, the study design. The last element of PICOTUS will be study design, whether it will be observational or it will be an experimental study. I will not go into detail of this because Dr. Usha Datta ma'am is going to take this in detail. So these are the elements of the PICOTUS question. For every research question, you will need to define these elements. So once these are defined, once PICOTUS elements are defined, then you have to look at FINER. It is not sufficient to just look at PICOTUS. I have also look at the elements of FINER, which are feasibility, whether the question is interesting, novel, ethical, and relevant. So first of all, feasibility. How will you look at feasibility? Feasibility is inherently connected to population, intervention, comparison, outcome, time frame, effect size, and study design. All of these elements will directly impact the feasibility. You have a very good PICOTUS defined, but do you get that particular population? If you're defined, as we defined our inclusion criteria, exclusion criteria, do you get that kind of population in your study, whatever population is available to you? If the sample size is 1,000 women, do you have access to 1,000 women? If you need placebo, do you have access to placebo of calcium tablets? If you want to look at outcomes and the time frame is 9 months, so if you want to include 1,000 women and each woman to be followed up for 9 months, will it be feasible within the time frame you have? So all these PICOTUS elements will define the feasibility. And once you have crystallized, refined the question, written the research idea in PICOTUS format, first thing you should look at is its feasibility. Because if it is not feasible, then there is no point in going further. Okay. The next 3 aspects are interrelated, and we will take them together. These are whether the research question is interesting, novel, and relevant. These are related topics, and many times all of us face this rejection letters from editors. And one very common immediate rejection is this manuscript does not add anything new to existing literature, so we cannot publish this study. Why this happens? This is a way of reviewer saying, you did this, so what? So this usually happens if the study is not interesting, not novel, and it's not relevant. Although these are overlapping, these are distinct. Interesting means that in your specialty you find this to very interesting. So interesting may be a topic which is not clinically relevant, but you find it interesting. For example, in the calcium study which we're looking at, if you want to look at particular blood flow in uterine artery or levels of a certain biomarker in blood, you find it interesting, but it is not novel. Someone has already done it. So it is interesting, but not novel. No one has done it. It is interesting, it is novel, but it's not relevant to your population. You are doing a biomarker by flow cytometry or by some laboratory method, which can be done in 100 batches of 100 and has no clinical application. So reviewer may say it is not relevant. So look at your research question from these 3 angles, that in the end you don't get that answer or from the editor of the journal, so what? So try to answer your question yourself, that if I do this study, is it adding anything new? So this is very important issue with research which is conducted. The very important article in Lancet 2014, that this problem arises when the needs of potential users of research evidence are ignored and what is already known or already being researched is overlooked. So we do research which is in this waste quadrant. Neither it is relevant to immediate application, nor it is relevant to advancing knowledge. So very important. If you want to publish, try to look at this important aspect of, once it is feasible, next most important aspect is whether it is interesting, novel, and relevant to your needs of your population. So I think this I have already looked at, so I will not go into with this slide. Next is ethical aspect of your research. So when a study is not ethical to plan, when there is no equipoise. No equipoise means that in literature already you know that calcium decreases the incidence of severe preeclampsia, or calcium decreases the incidence of PIH, or improves the outcome. If it is already there, then what addition you are going to add by recruiting 100 women, 50 into calcium and 50 into placebo group? Or if already sufficiently large studies are conducted and they have shown that it is of no use, sufficiently powered studies are there, what additional you will get by doing a study? And this is not a question, just a research methodology question. This is a question of ethics. Why should you be exposing women to a potentially harmful drug or a useless drug? Or if it is already useful, why 50% of the subjects will be exposed to a placebo drug? So this no equipoise is a very important ethical question. So there is no role of doing experimental study for obviously harmful exposure. So you cannot do that. You cannot withhold standard treatment for experimental group, for the both experimental and control group. And you cannot have sample size which is larger or smaller than the required sample size. So look at all these ethical aspects when you're defining your finer E element of the finder. Now, once you have your research question defined, we looked at PICOTUS, population of interest, intervention, comparison group, outcomes, time frame, effect size, and study design. When you write this in a statement format, then it becomes a hypothesis. And when this hypothesis is written in a null format, it is known as null hypothesis. So I will say, giving among women who are 18 to 35 years of age and are planning pregnancy within next 3 months and do not have any essential hypertension, giving 500 mg of calcium every day for at least 6 months versus not giving calcium does not reduce the incidence of severe PIH from 10% to 7%. So this becomes our null hypothesis, which we need to reject when you do your study. And Dr. Usha Datta will further catch up hold it and then further look at what will be study design and how this hypothesis will be processed. To summarize, research idea comes from observations, experience, literature reading, sometime from intuition also, or priority list from funding agencies. It is important to list all research questions, filter and define the question by using PICOTUS and FINER. And spending time on selecting appropriate research question is this time very well spent. Maybe you need to spend a week or even a month to do it. And only then the next labor of next 12 months will be useful. So and in the end, I will say research question is the king, or you can say research question is the queen, but it must be worthy of sitting on the throne. Otherwise it will be a useless research. Thank you.
Thank you, Dr. Deepak, for an excellent presentation. You have presented such a difficult and important topic in a simplified manner. I am sure there would be a lot of questions which will be discussed at the end of this session.
Thank you, sir. Thank you.
Thank you. Thank you, Dr. Rana. And thank you, Dr. Deepak. With this, we move on to the next presentation. We've just heard about how to decide your research question. And now, Doctor, I would request Dr. Usha Datta to take the podium for addressing the next important topic, how to go about finding an answer to that research question. It's my honor to introduce the next speaker, Dr. Usha Datta, who is currently the professor and head of the Department of Gastroenterology at our institute, that is PGI Chandigarh. After having earned her DM Gastroenterology from All India Institute of Medical Sciences, Delhi, ma'am proceeded for earning several interesting positions as research fellows in international universities of repute. Ma'am has been conducting a lot of training sessions on research methodology, and without without wasting time any further, I would request you to kindly take the next topic. Thank you.
Thank you, Dr. Nusrat, for your kind introduction, and thanks to the Gynecology Department for inviting me here. At the offset, I would like to say that it is not possible to conduct a research methodology workshop in 2 hours. I know there is restraint of time, so we will try and just focus on the key aspects so that it is a primer to kindling your interest in understanding this very vital component of being a doctor, because we need to do research on one side. We also need to understand the published research. So unless we understand research methodology, we cannot do either of them. And whenever, as a good clinician also, you have to practice today, you need evidence-based medicine. So for which interpretation of existing literature is necessary. So I would urge all of you to minimum do a 5-day research methodology workshop wherever you can. So this is just a primer for you to be kindled into this area of learning. Fortunately, in the West, people are introduced into this course and curriculum during their undergraduation, and here it doesn't happen till very late. So that is why we have to fill the gap by learning it ourselves. So I will just speak on what is research. This slide exemplifies N, that is the population. Suppose I want to study all pregnant women in this universe, we will not be able to, because there will be, if on one particular day I want to do an international multicentric study on all pregnant women, it is not practically feasible or possible. So this population in which we want to apply the knowledge of whatever we learn in research, it can never be feasible to do it in the whole population. And that is always represented by the big N. And we take a representative adequate sample in our study, that is the small n. So that is a small sample. You remember, even if it is a very large sample size, it is still a small n compared to this big N. So even if I want to study in about 100 diabetics, but in the universe there are so many diabetics, even I make the study instead of 1 lakh diabetics, but still it will remain a small n in comparison to the big N. So we have to also always realize that when we extrapolate what we learn from this small n, we have to be conservative in our approach. So this small n, we have to observe and analyze very, very carefully, because this is a small subset that we are going to see. They have to be drawn in a representative manner, and as Dr. Deepak highlighted, there's a component of sample size calculation. So we calculate the sample size so that we have adequate representative sample. So suppose you take only upper socioeconomic pregnant women, they will be very different. You cannot apply it to rural socioeconomic women. Similarly, if you take only rural socioeconomic women, you cannot apply it to the upper socioeconomic women. So it has to be representative of the population at large, and so that you can extrapolate it to the larger thing. So if you do not take a representative sample, you have a lot of exclusion criteria, then your generalizability of the data becomes lesser. You cannot generalize that concept to everybody, like COVID vaccination. We studied it in all adult people, but we could not bring it to pregnant women because we never had pregnant women in the inclusion criteria. So this is a very common thing. Pregnant and lactating women are excluded from all studies. And then you have to extrapolate whatever data is there in other people for these people. So this is a problem of generalizability. But for improving validity, we have to have a fixed set of samples so that whatever we study in a small sample size, we can show the effect of difference. And we have to extrapolate it appropriately and conservatively. As I said, the small n is always small compared to the big N. So what are study designs? Study designs are of two basic types: observational studies and interventional studies. So it depends upon what you are going to do. Are you just going to observe? Are you going to see? You're going to intervene actively and see the response to the intervention. All these slides I will give you. You don't have to take photographs, please. So all these slides, I will leave it on this laptop. So observational study designs are of two types: descriptive and analytical. Whenever we have a control arm, it becomes analytical. Okay. Description is just describing one case, which becomes one case report. Many sets of cases of the same kind of thing, which you did a new novel uterine artery embolization for PPH. You did a series of 20 patients, you report that. So that becomes a case series. Cross-sectional is you have a case and a control, but you are doing it at a single time slot. I'll just show you. So cross-sectional, case, control, and cohort. So these are the three other types of analytical studies. So analytical means case versus a control. There has to be a case arm and a control arm. Out of these three, cohort is the king of observational studies. King or queen, as Deepak was trying to put. You can put king or queen of observational study. As you go from here to here, the complexity increases. The validity increases. Validity, unless a study is valid, nobody will believe it. Nobody believes it. Nobody can use it. So that scientific information is just on paper. It's of no use to the scientific community or to the patients. So more you go towards the cohort study, there's a final increased impact of the study. We have to realize that it is not only your effort which goes into doing a study, it is the community's effort. The whole institution helps you, the patients help you, the research staff help you, the labs help you. So to help putting that back to the community, you need to plan your study properly so that you get valid results out of it. So the key terms are exposure and outcome. All studies can come down to two terms. What is the exposure or the risk factor or the intervention that you're doing, and what is the outcome you're looking for? Say Dr. Deepak was talking about calcium, which was the exposure, intake of calcium, and the exposure was reduction in PIH, if I got it right. So it is doing exposure versus outcome, and you have to have a control arm in which presence of exposure or absence of exposure or a different in the level. Say in one group you're giving 100 milligram of calcium, in another group you're giving 500 milligram of calcium. So one becomes the case and one becomes the control arm, and in both of them you're studying the outcome. So if the outcome has already occurred, and you're going back to see whether there was a risk factor, like the typical study of say lung cancer has happened, and you're going back and asking, was the patient smoking or not? So you're going back in the past to ask whether the patient had smoking or no smoking. So this is like a retrospective component. Okay. So the typical classical common garden variety of retrospective study is a case control study in which the outcome has already happened, and you're going back in the past to ask whether there was exposure to smoking or not. The other way is you're going forward. Say you are taking people who are, say, pregnant right now, who have been enrolled into the antenatal clinic. You are following them up through the pregnancy and seeing, say, at the level of postpartum, what are the various outcomes, maybe neonatal outcomes, maternal outcomes. You're giving nutritional intervention to one arm, the other arm you're not giving nutritional intervention, and seeing what is happening at the end of the whole pregnancy. So it's a cohort. So the exposure is nutritional intervention, and the other one is patient who's getting the standard advice. And you're following up throughout the pregnancy to look at the outcome. So are we clear? So that one was retrospective, or say in the situation when a patient had come with PIH. So you ask in the past, did the patient have certain risk factors? So patient comes to you in the emergency at the time of delivery with PIH. You ask what were the risk factors during pregnancy. So that becomes like a case control study. Whereas here you're looking at the exposure to either calcium or to any nutritional supplement and seeing the effect of that on the development of PIH. Cross-sectional is something which we have to understand the terminology very clearly. Cross-sectional means you're looking at the exposure and the outcome at the same point of time. But you cannot say that this caused that or that caused this. So there is no temporality to it. Amongst the various causations, see, when we do statistical analysis, we find association. That means the p-value less than 0.05 means there's an association. But association does not mean causation. For causation, that association has to fulfill another 7 criteria called the Bradford-Hill criteria. I will not have time to go into those details, but the one component of that is temporality. That means you have to show that the exposure occurred before and the outcome happened after that. Say you gave calcium and there was a response after that during pregnancy. So if you do it at the same time, what was the patient taking calcium at the time when the patient came for pH? Maybe some practitioner outside PGI has already prescribed 500 milligram of calcium. So that doesn't mean the patient has been regularly taking calcium for the whole of the pregnancy. So on the day of diagnosis of PIH, if you just ask the history of calcium, that is just like a cross-sectional snapshot study. Whereas a cohort study is like a video tracking a patient over a period of time. So in a cross-sectional study, you cannot say that the patient the calcium exposure is directly associated with the outcome. So many studies which are actually done in institutions are cross-section study. You are taking the patient on one day, filling up a CRF, doing some blood sample. It is at that point of time, but you cannot say one thing is causing the other. In a case control, as I said, the outcome has already happened. Say PIH has already happened. You're going back in history to find out was there a particular exposure or no. Similarly, in a cohort study, as I said, we go forward in time. So basic concept of cohort is you're going from exposure to outcome. Basic concept of case control is you're going from outcome, going back and asking whether they had the exposure. And in cross-sectional, you're looking at both at the same point of time. In a randomized control trial, it is one step ahead, that you're allocating one person to get the exposure versus not get the exposure in a random fashion. So in a cohort study, what is happening, suppose I take students from Punjab University who are smokers versus non-smokers, and I'm following them up over a 15-year period to see if they are having any respiratory complications. So that becomes like a cohort study. But if I'm asking patients who have lung cancer, did you smoke, did you not smoke, and take that history, that becomes a case control study. But if I'm allocating somebody to smoking, I cannot allocate. Dr. Deepak said there's an ethical component in all study designs, that you cannot do something like you cannot give them cigarettes and start asking them to smoke. So that is ethically incorrect. So, but I can do one thing is that certain positive interventions like nutritional intervention, I can give it to one group and not give it to the other group and see what happens. So that those are ideal for randomized control studies. You allocate one group to receive one thing and allocate the other group to not receive. And this randomization is very essential to minimize bias. So what is a cohort is actually a Roman word, which is a defined group of people who share the same characteristic over a defined period. So all women getting into ANC, say in the month of March 2022 to 2023, all those women will be enrolled and followed up during the pregnancy. So it's something which defines this group of people. So that becomes a cohort. Traditionally, the cohort was used in a Roman army of a unit of 480 men. So cohort study in a nutshell is a defined group of people marching forwards in time from exposure to outcome. So for your left brain, right brain looks at words, left brain looks at figures. So here you have healthy people whom you are categorizing as exposed or not exposed, say smokers and non-smokers. So you take the history and find out who amongst them are exposed and not exposed, smokers, non-smokers. You follow them up over a period of time. So these red balls represent exposed and blue non-exposed. You follow them up over a period of 10 years or 15 years, and some of them develop disease, say lung cancer. And some of them also in the control group will develop lung disease because there are so many factors which can cause lung disease. It is not smoking alone. So that is why those are the confounders. Those are the factors which affect the exposure and the outcome. There are other factors, say asbestos smoking, indoor pollution, driving, various other exposures which can happen, which can also stimulate lung cancer. So you need to take that history in all the patients. And here you have disease among the exposed and disease among the non-exposed. So the yellow dots and the yellow dots represent the disease. So what you do, how do you do the analysis? Very simple. number of people who got the disease amongst the exposed. So the denominator has all the red balls. All the red balls is the exposed. And here, number of people who got the disease among the non-exposed. So that is in simple relative risk. So disease among exposed by disease amongst non-exposed gives us the relative risk. So the relative risk is high. That means smoking is more often associated to develop lung cancer. So in simple terms, this is what it is. So this is like a typical cohort study, and relative risk we can use for randomized control trial also. In case control studies, we use odds ratio because we cannot go forward in time, and we do not know the denominator. So I cannot go back into details about why we use OR and RR, but suffice to say that cohort studies and randomized control trials, we report it as relative risk, and case control studies as odds ratio. So here, how do we choose from exposure to outcome? Population with exposure. So all people who are, say, smokers in Punjab University, we pick up, and people who are non-smokers. And here you can always take a case to control ratio of 1:4 maximum for a valid statistical interpretation, because quite often in these situations you will get more controls than cases. Say if you want to study effect of radiation exposure, and you will get a small group who have had radiation exposure and a large group which has not had radiation exposure, and so you draw out a sample from each one of them. So to optimize your study design, you can have maximum of 4 controls for one case, and then you follow them up over a period of time. It's very important to ensure that they already don't have the disease in question. So a baseline chest x-ray to obviously getting a baseline CT scan may not be appropriate, or maybe a baseline chest x-ray and symptoms to say that they don't have the disease of interest. And then you follow them up over a period of time. You do not know the outcome. And then you see some will develop outcome, some will not develop the outcome. So that is how you assess a standard cohort study. So having cases in control doesn't automatically make it a case control study. In all studies, we will have cases and we will have controls. You may call them intervention group, control group. You may call them depending on whether it's a randomized control or otherwise. So the type of cohorts are descriptive cohorts, analytical cohorts, and interventional cohorts. So descriptive cohort typically say hepatitis B, patient followed up over 15-20 years, natural course of hepatitis B. Some may develop chronic hepatitis, some may develop HCC, some may develop cirrhosis, some may die, some may clear the virus. So just describing this cohort becomes a descriptive cohort. Are we clear? Now, analytical cohort, you take a group of hepatitis B and you take a group without hepatitis B and follow them up over a period of time and see whether there is any difference in the outcome. So that becomes an analytical cohort. So you have a control group. So you have patients or smokers, non-smokers, you look for any particular malignancy as an outcome. So that becomes an analytical cohort. Interventional cohort, you are intervening. Say one group, one village agrees for a particular vaccination. Say COVID, some village agreed, some village did not agree. You have intervened and you are following them up over a period of time to see whether what is the incidence of COVID in the community. So that becomes an interventional cohort. Then comes the term of prospective and retrospective. The Park and Park old book had this confusion that all case control, it clubbed it as retrospective and all cohort as prospective. And that is the reason there is some confusion in people's mind. So just to clarify, if the disease has happened, and then you're going back in the past to ask was there an exposure or not, it becomes a retrospective study. If disease has happened, it's a retrospective study. If disease is yet to happen, it's a prospective study. Okay? So if disease, you may be enrolling patients prospectively, but that doesn't make it a prospective study. The prospective study, it is dependent on disease has happened or not happened. Okay? Yes?
At the time of the disease has occurred,
Yeah.
at the time of we had that case.
Yeah. Thank you, Dr. Narayan. So Dr. Narayan has clarified, if we say disease at the time of recruitment has occurred, then it is a retrospective study. If it hasn't yet occurred, it's a prospective study. So in this, you see a prospective cohort versus an RCT. What is the difference? Here it is naturally allocated group, that is smokers versus non-smokers. And here you're randomly allocating them to give calcium versus no calcium. So that is because you're randomly allocating, otherwise everything is the same. You're going from exposure to outcome. Essentially, RCT is a cohort study in which you have just allocated it randomly. Okay. That is why cohort study, if you understand, then everything becomes easier. So that is the mother study for this component. So what is a clinical trial? A clinical trial is a research study that prospectively assigns human participants. So clinical trial relates to only humans to health related intervention and to evaluate the effect on health outcome. So it's very simple, intervention to outcome. Clinically, we are assessing. Madam, we can give you the slides, so don't worry. Focus on learning whatever you can, and then we'll give you the slides. Validity of a study design. Why do we choose randomized controlled trial? So now from cohort, we move to randomized controlled trial. Randomized controlled trial is at the top of the pyramid of validity, of the quality of the study. And here we want systematic reviews combines all randomized controlled trials and also can combine cohort studies. But however, we will focus here today only up till randomized controlled trial. So why do we randomize? It is to reduce bias. Otherwise, lot of studies have selection bias. Koi patient who's likely to do well, he gets included into one arm versus the other person gets included into the other arm. So in order to remove the bias of the investigator completely, it becomes we do randomized control. After you make the protocol of the randomized control trial, you are a slave to the protocol. You are a slave to the protocol. After that, you cannot change. So that is why what Dr. Deepak said is very important. Understand your research question, plan your study design, write your research protocol, go over it 5 times, do a pilot. And once you freeze the randomized control study protocol, then you cannot change. Then you have to just follow it like a slave. So that is why it is very important to understand that it's important to pilot and understand the science behind it and the practicalities, the feasibilities of doing things. So it removes the selection bias. Then randomization does not and should not guarantee equal numbers in both the groups. Because if you can have 50 in one group and 68 in the other group. It doesn't mean you should have 50-50 and 40-40. If I see a randomized control trial which comes to me as a reviewer and I see exact numbers, I always raise my eyebrows because it is usually not the case why you have equal numbers on both arms. It is just to ensure that the confounders are distributed nearly equally, but need not be nearly equal, because in these small randomized control trials, you cannot get equal distribution of confounders. So actually speaking, ideally you need large randomized control trials with simple questions to answer the problems in the community. So why do we randomize? I cannot again go into all this detail. Any patient whom you are following up, there are various things which are happening. Apart from that 500 milligram of calcium that you're giving, various things are happening. Patient is taking extra milk. Somebody comes and tells, take dahi. Somebody comes and tells, says, gives something else. Somebody gives some vitamin D. Somebody has a better, healthier lifestyle. Somebody is reading internet and doing things. So many things are happening in the patient's life, not only your calcium. And patient may have per se a better bone mineral density to start with, better genetics. We do not know. So there are patient factors. Observer factors. It depends upon how you are going to observe. The patient who is taking calcium, you may record that his quality of life is higher than the other one because there is a subjective component in those components. If you're measuring calcium, I can understand is an objective parameter, but there can be subjective parameters. Then there are co-interventions as we discussed, which the patient may be taking some more dahi, some more sunlight, some more something. Hawthorne effect. Anybody who's being observed will perform better. So if I focus my attention on just one of few people who are attending this lecture, they'll be more attentive. If I don't focus here, then they'll be less attentive. So it is just that when you're under focus, spotlight, you will do better. And then regression to mean. If you measure somebody's blood pressure today, it's 140/90. If you measure over a period of time, it will tend to go towards the normal values. So that is what nature is. It will go towards normal values. So just reduction in blood pressure doesn't mean that the drug you gave caused the reduction. So that is regression to mean. And then is the drug effect. So in a randomized controlled trial, what you are seeing an observed effect of say 30 milligram, 30 mm reduction in blood pressure, but it is, and you attribute it to the drug. Actually, many other things are also happening alongside. So in order to take those things off, to say that the observed difference is due to the drug, we have to do, by randomization, you remove all the other components in the whole process. So RCTs have a lot of problem. If you read any meta-analysis, you'll realize there is a lot of various kinds of biases. We have to minimize those biases, so that's why planning it becomes very important. So there are terminologies. Dr. Deepak already alluded to effect size, randomization, blinding, allocation concealment, stratification, surrogate outcome, and intention to treat analysis. So these are all new terms for all of you. Many of you may be familiar with some of them, but I will just briefly touch on each of these terms so that these concepts are clear. So clinically significant difference. Somebody comes to me and says that this drug will reduce blood pressure by 1 millimeter mercury. Yes, can anybody in this row number 4, tell me, will you prescribe that drug? No. Somebody says next row 4 millimeter reduction in blood pressure. Will you prescribe the drug? No. Somebody says 10 millimeter reduction in blood pressure. Yes, the row behind, will you prescribe the drug? Yeah, you may if the risk of the drug is not too high. So you will always measure the risk and the benefit. And somebody says there's 20 millimeter reduction in drug, but there is going to be certain risk factors to the neonate or the fetus. Would you prescribe the drug? No. So you as a clinician are trying to weigh the risk and the benefit in order to see whether you want to prescribe that drug or not. So it's always a risk-benefit ratio. So effect sizes, how much difference does a clinician need to start using a drug? That is what ultimately you want another clinician to use. Say you start a drug for pregnancy, induced hypertension, you start a new drug, you want to see, say that, okay, this drug is better than the other. So how much reduction would you think as a clinician is significant? Statistically, significance has no meaning here. Statistically, even if 1 millimeter is significant, still you will not prescribe. You will prescribe only when you think clinically it is relevant to you as a clinician. So how much difference is expected in the outcome? So I would prefer any drug which will bring down blood pressure by maybe 10 millimeter of mercury. That is my effect size. What is the direction? We would have to see what is the directional difference, whether superiority, inferiority, or equivalence. Again, I won't have time to go there. So in an RCT, what we are doing is study subjects. We don't have much time. We randomize them to receive the drug or the placebo. Again, follow up over time. Some people show reduction in blood pressure. Some people do not show reduction. And we again calculate the relative risk. So in an RCT, you check out people who are eligible for randomization. Once they are randomized, they cannot be dropped out. So you have to ensure that they stay within your study as far as possible. Ensure that you ensure that they are in your net. Once they are there, then you cannot lose them. So be very careful once you get them into your group, and one group has intervention and one has placebo, and you do an intention to treat analysis. That means once you have randomized them to receive intervention, whether they took the drug or they did not take the drug, they remain in this particular arm. Per protocol is, if they took the drug the way you wanted to them to take, then that becomes per protocol analysis. So if they were randomized to receive a drug and they took it or they didn't take it, they dropped out, whatever happened to them, they died due to a road traffic accident, still they will be in your intervention arm. So that is intention to treat analysis. Per protocol is they will do it the way you wanted them to do, then that comes into per protocol. So you need a comparator arm. And as Dr. Deepak said, if there's no standard treatment, you use placebo. If there's a standard treatment, you should use an active control arm. We will not have time to go into this. How do we randomize? We randomize them by, you can do simple randomization. Nobody does it today. We can take computer-based randomization, web-based randomization. And there are various web-based softwares. I use sealedenvelope.com. This is a randomization.com. So you can specify how many patients you want and how many blocks. This is very simple. There's nothing so difficult about it. If anybody wants, you can come to my office. I'll just show you in 10 minutes how to do it. So then you end up getting placebo. So you get a list of patients and what they will get. This you send it to your pharmacist. You don't do the randomization yourself because you don't want to be biased कि patient एक को placebo मिलेगा कि fluconazole मिलेगा. So what you will do is you will ask somebody who's not involved in the study to teach them how to do it. They do it. They send it to the pharmacist, and you then get only these vials. I'll show you the vials. Yeah. So you, if it is an intervention, suppose somebody has to get a lap hysterectomy versus a vaginal hysterectomy, you cannot blind the surgeon, you cannot blind the patient. So there we use the sealed envelope technique, in which inside the envelope you put whether the patient will get this procedure or the other. How much time do I have, Dr. Nusrat? 5 minutes. Okay, thank you, Nusrat. So one is this method. The other one is with those numbers, intervention control, you can put them into serial vials. You can have serially labeled vials or serial envelopes. Depending on if it is a blinded study, it will go into serial envelopes, 1, 2, 3, 4, 5, serial vials. So the nurse will not know what she's giving, the doctor does not know what they are prescribing, and the patient will not know what they are getting. So it will be in identical envelopes, identical solutions, which will not be able to differentiate whether it is the intervention or the placebo. And as I said, in an open label, you will have envelopes. So coming back to here, we will not have time for this. So blocking basically means that if you have to suddenly stop the study, you will have near equal numbers. Suppose I plan a study with 100 people, and because of COVID, I have to stop it at 40 patients. And I have 30 patients in the control arm and 10 patients in the intervention arm. Then how do I do an analysis? So that irrespective of wherever you stop your study, you will have near equal numbers in both the groups. So it is just to ensure that component. So blocking here, you can see, you can have these 6 people, you have 3 red dots and 3 blue, then again 3 red dots and 3 blue, 3 red dots and 3 blue, 3 red dots and 3. So these are blocks of 6. Okay, so these are called blocked randomization. But here, you know, after I know that 3 people have got the blue and 2 have got the red, I know the 6th person will get the red. So I cannot conceal that allocation. So in order to avoid that situation, I have randomly allocated blocks of varying size. So it could be a block of 4, then a block of 8, then a block of 6, then a block of 4, then a block of 8. It can be any order. The block size can be of any order. So I don't know when I'm doing this, is the block ending here or is the block actually a block of 8? So I cannot ever predict what the other person will get. So permuted block randomization, that's what this is called, permuted block randomization of varying block size. So this allows me to completely conceal the allocation. And then we stratify, suppose we want males and females separate study, or if we want primipara, multipara in separate study, then we can stratify individually. Okay. We discussed this. So just a simple dengue papaya study. Everybody says dengue or have some papaya. Now you don't know whether it actually works or it doesn't work. Some platelets increase. Naturally also platelet can increase. So we never know that it's papaya which caused the improvement. So you have to have a control arm. So you have to have a control arm, and platelet increases in one group versus the other group. So then you can also have mean platelet levels which have increased in the other. Here I've also specified that how much papaya, 30 ml of some extract, You have to standardize your intervention also. And then you want to say that, okay, 30 ml in this group, equivalent placebo, then you have randomized them to receive one group to receive one versus the other. And then you want your parameters to be objective. You say number of people in whom platelet increased by 5,000. It was 70% in this group and 20% in this group. Okay, so this is a simple study, randomized controlled trial. But there are caveats to this. What is it? You have to ensure that they were randomized. Not that the best patients went to this arm and not the others went here. So in order to avoid selection bias, patient should be blinded. So this placebo has to be identical. If the patient knows I'm drinking papaya, he knows that papaya se improvement hoga, some endorphins will be released. Patient will have some placebo effect with even this. Next is allocation consent. You should not know who should get the next one. So suppose there is a very sick patient with already headache, intracranial bleed, you're suspecting, you say, nahi, nahi, isko papaya extract de do, iska jaan to bachana hai. So you should not be using the study results to help patients in that study design. That's the problem with the randomized control trial. Once you start till finish, you cannot use what you're learning from the study for the next patient. So that is a problem with ethical issues, but you have to just do that for the larger ethics of the study. And observers should be blinded, so you should look at the platelet count, not manual platelet count, but actually the platelet count at that thing. And even if it is manual platelet count, the pathologist should be blinded to knowing whether the patient received papaya or this. Patient selection blocking, as I said, so that we have near equal numbers in both the arms. Outcome should be objective. You should register all prospective randomized controlled trials in CTRI. If you do not register, it will not get published. So randomized controlled trials have to be registered to be published. And this takes some time. So ensure that you are in time to do that. And just getting a number there doesn't mean registration. You have to get a thing that you have got a proper registration in just putting your study into that doesn't mean registration. They have to approve it and tell you that it's registered. And statisticians should be blinded and consort guidelines should be followed. So steps in the process, as Dr. Deepak highlighted, problem you identify, maybe dengue, you are wanting to give papaya, maybe it is PIH, you want to help it with calcium, you want to do any such intervention. Formulate it into a research question in the PICOTS format. Write your hypothesis in words. In your research protocol, thesis protocol, put a box which says hypothesis. In a layman's language, you can write one hypothesis. In a scientific language, you should write one hypothesis which clearly says giving 40 milligram of this particular drug will reduce blood pressure by this much in these many people, how you have selected your patient, everything, all your PICOT should be spelled out there. Then the study design, as we discussed, we won't have time for sample size calculation here. And here you have to get an ethical approval. You have to write your protocol. And I said your protocol should not be written one day prior to your next day submission. That's what happens. And that is why it is very important to allocate the thesis guide 2-3 months in advance to the students so that they have time to write their protocol, register the trial, conduct the study, and analyze. I will not go into this. Blinding versus masking. Ophthalmologists don't like the word blinding, so we can use masking. And everybody should be blinded. The subjects, the patient administering the intervention, co-intervention, patients measuring the outcome, statisticians. So all of them should be blinded, and you should mention who all were blinded. Just saying double-blinded, triple-blinded does not make sense. And interventions, you should also notice if you're doing a drug trial, you should know when does the drug expire. So you have to have a clear idea that the drug is fresh and would last for the duration of the study. The brand name, the manufacturer, everything should be mentioned. The dose regimen, which batch, note the expiry date, and ensure that your follow-ups are as good as possible. For less than 20% in field trials is acceptable, less than 10% for hospital-based, and less than 5% for efficacy-based trials, efficacy trials. And outcome variables should be what is relevant to the patient. Patient is interested in his survival, in reduction of pain, reduction of hospital stay. Patient-related outcomes should be mentioned, and secondary outcome variables should be listed. Most often, these are surrogate variables, an improvement in CRP, a reduction in some parameter, some blood parameter, but the patient is not interested in all that. Patient is interested in what matters to the patient. So your primary outcome should be a patient-related outcome. So choosing an appropriate patient-related outcome, and nowadays we also use all-cause outcomes. So you can have a composite outcome, and then beware of surrogate outcomes. Improvement in CRP, but the patient dies. That is of no use. So golden rule for randomized control trial or all studies is failing to plan is planning to fail. So you have to spend adequate time at the time of planning, and planning is not only sample size, it is actually choice of your research question, the study design, your study methodology. If there is a scope of bias, there will be bias. So you have to ensure that you minimize that as much as possible. Once you randomize, avoid exclusions or losing the patient. And if you did not mention in the protocol, it means you never intended to do it. So quite often our protocols are poorly written, so we need to pre-specify our outcome. And there is no perfect study, and there can never be a perfect study. But you do your best, given the circumstances, you do your best. So summing up, clear research questions, select best feasible study design for your study question. For some studies, you can do only case control. For some, you can do only cross-sectional. For some, you can do randomized control. So choose according to the feasibility issues, which Dr. Deepak very nicely alluded to. Choose your outcomes very carefully, which you can establish in your study in a valid way, and calculate your sample size. If you can do a RCT, that is the best. Even if it is a small RCT, it is better than a cross-sectional or a cohort study. Allocation concealment should be flawless. Blinding is highly desirable wherever it's possible. Minimize exclusions after randomization. Preferably use intention to treat analysis. Results are expressed as relative risk and as number needed to treat. And follow consort guidelines for the same. Thank you.
Without much wasting any further time, I would request Dr. Kamal to continue with the moderating the discussions. Thank you, ma'am.
Thank you.
Hello. Yes. Fantastic presentation by Dr. Deepak and Dr. Usha. I'm sure students must have learned a lot of things, the finer criteria, peak codes, and some other aspects of the framing a question and how then to properly select a study design in order to undertake those studies. Number one. So with their presentation comes a clarity into the mind, but with clarity comes the confusion, which reminds me of some lines which says, no study, no confusion, little study, little confusion, more study, more confusion. I do not know whether you are more confused or more clear. You can ponder upon that answer maybe a bit later. Now, but coming to the question here first, which is posed by the student is, to maybe Dr. Usha, is it possible to report data from some part of the study while other parts are ongoing?
Yes, it can be done. It is called an interim analysis. So usually these things are done a priori. You plan a priori that you can do an interim analysis. When you are doing interim analysis, your sample size goes up. Your p-value, you have to be more conservative, because when you do multiple testing, you will increase the alpha error. So it is usually not recommended to do an reporting, midway through the study, because it can be, does not reflect the whole sample that you had planned, the whole study design that you have planned. But if it is something extremely novel, it's going to change the way world is going to think about that disease, it is necessary for that particular thing. Say during the COVID pandemic, you planned a study with 1,000 people, with 200 you have got a response. Say you gave chloroquine, patients had tachycardia, you don't want it to continue, there you can report. But just to report a part and leave the whole behind is not a good idea.
Right. So just a follow-up to this, what if the study is terminated before all cohorts have completed?
Yeah, as I said, then you have to have caveats. Your p-value has to be taken at a lower cutoff. Otherwise, you will end up having, if you take at 0.05 when you have recruited only 1/3 of the patients, you can get a false alpha error in your analysis. So unless it is a game-changing thing, you can always report it with a caveat, but otherwise it is not recommended.
Maybe the next question, what logistical planning is required when including an interim analysis?
So all these three questions seem to be related. Maybe they have come from single person. So if you are planning interim analysis at the planning stage itself, how many interim analysis will be done, at what stage it will be done, and there has to be a data safety monitoring board who will look at the interim analysis and make a recommendation out of it. And then rules of the recommendation have to be studied priori. So there are many aspects of this. So this interim analysis, premature stopping, these are, I think, larger topics which need to be understood before you embark on doing these things.
Right. So the final question from the participant is, what is strobe? How can it be used in our studies? Or how it can be used in the studies?
True. What is okay, strobe guidelines. So there are various checklist guidelines which are there for different kind of study design. Strobe guidelines are used for observational studies. So when you report these observation studies, which are case control study or cohort studies, so there are elements of the study which need to be reported, starting from what should be title, what should be all there in the abstract, rationale of the study, how subjects were chosen, and so on. So different elements of the observation studies are written in the strobe checklist, and and there are articles which are known as elaboration articles. So there will be strobe checklist, there will be elaboration articles. One can have a look at them while you are reporting studies. They are meant to be used when you are reporting study, but they are also useful when you are planning and writing the protocol. So strobe is one of the many guidelines which are available for different study designs. One can look at the Equator Network website, and you will find the compilation of all the different study designs, reporting checklist available there.
We have 2 minutes. So maybe
another question I would like to ask. Sir, what is the right time to do a CTRI registration for a study? And are only randomized controlled trials needed to be registered, or all observational studies also have to be registered for publication?
So right time for CTRI registration will be once your protocol is written, and CTRI registration requires ethics committee approval letter to be attached. So protocol written, ethics committee approval should be there, and then you need to upload. So clinical trial registry by name itself means it is for clinical trials, but many people also register their observational studies also. There's no hard and fast rule that it will not be published. If observational study is not registered, it is only published, but clinical trial registration is mandatory.
maybe, sir, one final question, because we still have 1 minute. Some people are born researcher. Some have a research thirst upon them. So I face this question many a time when students ask, I want to be a clinician. It's a general question, how I want to be a clinician, but I need to do the research. So how to make that balance or start to give them that, yes, research may improve their clinical practice, or how it is going to help them in their routine clinical practice? Thank you.
So I think it's a big question. Whatever opinion I can say, that you may not be able to do research, but you should be able to interpret and take a message from research which is published. I think Dr. Usha gave many examples from COVID outbreak. And as a person who is practicing medicine, there were many art studies which were coming, many publications about vaccine, diagnosis, use of mask, many things. So when you want to interpret these findings, you have to be research literate. Like in your CV, I think you wrote, I want student to be data literate. Similarly, people should be research literate. They have to know how to read research, look at limitations, strengths, So at least that should be part of the training. Later on, one can become clinician. All of us are clinicians. Some of you, I disagree that people are born researchers. They have to, it is a hard task. You have to learn it. You have to practice it, and still you will not be a perfect researcher. So some training is needed. Some will find interest, will become researchers, but at least you should know how to read research. Thank you.
Yeah. Deepak has already highlighted the key components. One thing I would like to say is, by learning research methodology, you will become a better clinician. Because as a clinician, you have to practice evidence-based medicine. So unless you know how to interpret the evidence which is coming, otherwise you will just read the conclusion line of a randomized control trial, and based on that you will start practicing. But if you realize, as I said, there are so many flaws, biases which can happen in randomized control trial. So just reading the conclusion of the abstract should not become the starting point for you to prescribe or not prescribe a particular intervention for a patient. So learning research methodology, even if you don't do research as a career, it is important for everybody to do 1 or 2 research studies to understand what actually it means, the practical components of it. Once you do that, you will be able to interpret other study results. And also, as I said, it's important for all of you to go through a primer course for minimum 5 days, minimum 5 days on research methodology a couple of times, because it's a concept which has to be learned. And as Dr. Deepak highlighted, you're not born researcher, you have to train yourself in this process.
I'm thankful to the speakers for their views on the topic, and I'm sure the participant must have learned. And thank you very much. We are closing the session. Thank you.
I would like to thank all the chairpersons for lending us their precious time on a Saturday afternoon, and also thankful to all the audience for the diligent discussion followed after the speakers. So with this, now we would like to go on to the session second for the day. I would like to take the opportunity to introduce the chairpersons for this session. First, Dr. Lakshmi Narayan. He is currently working as a professor in the Department of Anesthesia and Intensive Care in the Postgraduate Institute of Medical Education and Research, Chandigarh, and he is the India coordinator of DM Intensive Care. He has multiple publications relevant to research methodology to his name. Sir, I request you to please take the chair. Next, inviting Dr. Vanita Suri, who is the professor and head Department of Obstetrics and Gynecology, PGIMER, Chandigarh. She is the program director of ICMR and WHO Collaborating Center for Research in Human Reproduction. Madam is the president of Association of Gynecological Oncologists of India, Chandigarh chapter, and president of FOGSI North Zone. With more than 250 publications to her name, she is well known for her areas of interest in the assisted reproductive technology, infertility, preventive oncology, heart disease with pregnancy, and medical surgical disorders of pregnancy. Ma'am, I request you to please take the chair. And with that, the third chairperson for this session is Dr. Ritesh Agarwal. He is currently working as Professor, Department of Pulmonary Medicine, PGIMER, Chandigarh, with his areas of interest in allergic bronchopulmonary aspergillosis, interventional pulmonology and meta-analysis, with more than 500 publications to his name in peer-reviewed national and international journals. He is the receiver of multiple awards for his exemplary work in the field of allergic bronchopulmonary aspergillosis. Now I request Dr. Lakshmi Narayan to please introduce the first speaker.
Good afternoon, everybody. I have great pleasure in introducing my friend, Dr. Saurabh Datta. We have known each other for a long time. He is a professor of neonatology in PGI Chandigarh. He is also an adjunct clinical professor in McMaster, Canada. He is very deeply interested in research methodology, and the one thing I can tell you is that he has got very clear concepts about what he is talking about. No foggy concepts here, right? So he is going to talk about approach to statistical testing rather than what is actually listed here. He has been listed as talking about interpretation of results, but he's going to talk about approach to statistical analysis.
Thank you, Dr. Narayana, for that friendly and kind introduction. I decided to change the focus of my talk because, there's only so much you can cover in 35 minutes. So I thought, let me at least focus on approach to statistical tests. There are a lot of terms involved and which is sometimes confusing to people. And I'm going to try and keep it as simple as possible and leave a little time for interaction and discussion at the end. So, when you have the data from your study available at the end of the study, and now you have to analyze the data, the first question you ask is, what am I dealing with? Am I dealing with, can we have a little more light, or is this preferable to everybody? I usually like being able to see the faces of the people in the audience. Can we have a little more light in the auditorium, please? Okay, so am I dealing with a single group of subjects, or am I dealing with two or more groups of subjects that I'm comparing with each other? If I'm dealing with a single group of subjects, am I doing something extremely simple, like just describing a simple variable, like in a descriptive study, for example? Am I just describing systolic blood pressure amongst diabetics? Or am I comparing two continuous variables to see whether a change in one is related to a change in the other? For example, if I have a bunch of hepatitis patients, just one group, in everybody ALT and AST have been done, and I'm interested in knowing whether change in ALT is associated with the change in AST. So that's simple a question, okay? Or is it a single group of subjects in which I'm comparing two observers? That means there could be two people, or observers could even mean two instruments or two methods of measuring the same thing. So it could be even that when I say observers, to see whether their observations about each subject are in agreement. For example, I have a single group of subjects in all of whom glucose estimation was done, but they were done by two glucometers for every patient, and I want to see whether those two glucometers are in agreement with each other. Moving on, am I dealing with two or more groups of subjects which I'm comparing, so between which I'm comparing the proportion of subjects who have a binary outcome? So that means the proportion in one group is being compared with the proportion in the other group. For example, the proportion of responders who are allocated to, say, the Tamiflu group or the oseltamivir group versus a placebo group in patients who had, say, H1N1 infection. So there are two groups, one who received an intervention, one who didn't, and the outcome is binary. They either responded or did not respond, died or did not die, had sequelae or did not have sequelae, etc. So it's a binary outcome. The proportion is being compared between two groups, or maybe three groups. So we have, it's two or more groups of subjects. Finally, am I dealing with two or more groups of subjects between which I'm comparing the distribution of subjects who have a numerical outcome? So that means the outcome is not categorical. It's not died or did not die. It's not a yes or no situation. It's a numerical outcome, say milligrams per liter or something like that, or height or weight or whatever. For example, mean, say, urine output in a dopamine group versus a dobutamine group in a trial comparing dopamine versus dobutamine. So as you can see out here, you do need to know whether when you're dealing with numerical data, not categorical data, numerical outcomes, whether that variable is normally distributed or not. So that's one of the first decisions you need to take when you're dealing with anything which is a numerical outcome. So how do we know our data is normally distributed? Well, this could be an entire lecture by itself, actually. But I'm trying to summarize a few simple things in one slide. So there are a few rules of thumb. You can.
Can you just tell them what is the categorical data versus the numerical data? I don't think that has
Okay, fine. So categorical data is where patients are being slotted into categories. That means they've either died or not died, had sequelae, no sequelae, they are male or female, they are preterm or not preterm, etc. So everybody is in a category, and there may be more than two options for a category. So they could be very preterm, moderately preterm, or term, there are three categories to it. Whereas numerical data is where the variable is expressed as a number. For example, the weight of patients, the blood pressure of patients, the height of patients, central venous pressure, etc., how long they survive, number of days, etc., where it's being expressed as a number. So they're not being slotted into categories. Okay. So some of the rules of thumb are you know, make a graph and you see whether it looks normally distributed, whether it looks bell-shaped or not. If it looks bell-shaped, there's a very high chance that it is normally distributed. And a few other rules of thumb. If your standard deviation is more than half the mean and calculated values at mean either +2 or -2 standard deviation look absurd to you, then chances are it is a skewed distribution. For example, if someone tells me that the gestation of live-born babies was 32 ± 6 weeks, and of course nowadays the convention is not to use a plus or minus sign, but just put it in brackets, mean in brackets standard deviation 6 weeks, then mean -2 standard deviations would mean 32 minus 12, because 2 times 6, right, would bring it to 20, which we do not consider to be live births as far as, you know, definitions by WHO and country-wide definitions are concerned. So when it becomes an absurd number, then you should start suspecting that probably it was a skewed distribution, wasn't normal to start with. And if the median value is far away from the mean, again, I don't think we have the scope of the lecture would be to get into what is median and what is mean, but if it is very far away from the mean, and that's again a matter of, you know, judgment, chances are it is a skewed distribution. There are, of course, some statistical tests to add a little more sophistication to the decision. So there's something called skewness, which is available in many packages like SPSS. If the skewness is more than double the standard error of skewness, it is likely to be skewed. Then there are some named tests like the Kolmogorov-Smirnov test, the Shapiro-Wilk test, and so on and so forth. In all these tests, if their p-value is significant, the distribution is skewed. And there's an easy way to remember this, that in all these tests, S is equal to S and N is equal to N. If it is significant, it is skewed in any of these tests of skewness. Non-significant is not skewed. And there are some more kind, you know, plots, P plot, QQ plot, etc., which are used for determining normality. Okay. So having done with this, we move on to actually how do we go about deciding what test to use. So the simplest of situations, if we are describing a single variable in a single group, you're not really applying any statistical test. This is just descriptive statistics. So first question you ask, is it binary? For example, subjects who have asthma, yes or no, you've done a survey in the population, you describe it as a proportion or a percentage. That's, simple. Or is it a numerical variable? If so, is its distribution normal or skewed? If it has a normal distribution, then you would express it as mean plus or minus standard deviation, or mean in brackets standard deviation. And if it is skewed, you would prefer to express it as median in brackets the first comma the third quartile. First and third quartile roughly correspond to your 25th centile and 75th centile. And I'm not going into it. That's an entire sort of talk by itself. Okay, so we now come to the second of those questions. So am I dealing with a single group in which two numerical variables or two continuous variables, I'm interested in finding out the relationship with each other. That does a change in one result in a change in the other? So for example, AST and ALT, or the old-fashioned way of calling it SGOT and SGPT, in a single group of hepatitis patients, the question is, does a change in one, is it associated with a change in the other? It could be, say, a single group of acute kidney injury patients where I want to know whether a change in urea is associated with a change in creatinine, and so on and so forth. So I get all the values from all the patients, plot it on one axis, plot the value of the other variable on the y-axis, and this is a scatter plot. So each dot corresponds to a single patient, and you can find out for that patient what is the SGOT, how much is the SGPT. So if any one of the two, if even one of the two has a skewed distribution, the test you use is called a Spearman's coefficient of correlation. Spearman's coefficient of correlation is used if either both are skewed, or even if one is skewed, you use Spearman's coefficient. Similar thing, if both happen to be normally distributed, then you use Pearson's coefficient of correlation. So it gives you the extent to which these two things are correlated, the magnitude of the effect. You will also get a p-value, which will tell you how often this kind of a relation could have occurred just by random chance. So p-values are of course dependent on sample size. So you take a huge sample size, you'll get a significant p-value. But what is even more important than the p-value is the magnitude of the extent of correlation, which you get by this coefficient of correlation. And this ranges from -1 to +1. +1 means absolutely perfect correlation. 0 means there is no relationship. Minus means a negative relationship between the two variables. We now come to the third question. Am I dealing with a single group of subjects in which I'm trying to look at an agreement between two observers? So if what I'm analyzing is categorical, say suppose there are a bunch of slides from patients with suspected malignancy sent to two cytopathologists, and each of the cytopathologists is rating it as cancer or no cancer. It's binary. Either there's cancer or there's no cancer. So the same set of slides is given to two people, and you're seeing to what extent do these two pathologists agree on their diagnosis on the slides. Then for that you use something called Kappa Statistics. Kappa Statistics is a value that you'll get between 0 and 1. 1 means there's a perfect agreement between these two cytopathologists, and 0 means that the agreement between them is no better than random chance. Okay. On the other hand, if the variable is numerical, say supposing it's the glucometer example, so it's in milligrams per deciliter is a numerical variable. So two glucometers are analyzing every blood sample which is coming from say 100 patients, and you want to see whether they're both arriving at the same value, agreeing on the same value of blood glucose, then you don't use Kappa Statistics. There are several methods which I will not go into detail, but suffice it to say that one of the important methods is to construct what is known as a bland Altman plot to look for agreement. You can also use intra-class coefficient of correlation, which is sort of a derivative of the coefficients of correlation, except that here you're actually trying to look at agreement, to what extent do two values agree. Okay, we now come to a situation, the second part of that big question, which we deal with very often in our day-to-day research practice and clinical practice, and that is when we are comparing two groups. We are often comparing two groups. So for example, supposing we are comparing a treated group and an untreated group, whatever may be the treatment, and our outcome variable is binary. For example, response to treatment. Responders versus non-responders is the binary outcome. So for example, suppose in H1N1 patients, half of them are randomized to a Tamiflu arm, half are randomized to no Tamiflu arm. Outcome is responded, did not respond. So you'll end up with a 2-by-2 table basically. So what are you trying to do? You are trying to compare the percentage which are in the treatment arm and the percentage who have responded in the untreated arm. If all these 4 cells in this 2-by-2 table have an expected count, and this is not the observed count, but the expected count, more than or equal to 5, then you use the chi-square test, which again goes by this name, same statistician Pearson, who divides the correlation coefficients. It's Pearson's chi-square test. And maybe if someone asks a question, I can take up what is the meaning of expected versus observed. So it's not what you actually observed when you did the study, but what you would have expected had there been no relationship between the treatment and the outcome. So if all these 4 cells have an expected count above 5, you use the chi-square test, which we are, I mean, most of us are familiar with that test. However, if any one or more cell has an expected count less than 5, then you use a Fisher's exact test instead of a chi-square test. Okay? So 2 tests with which I think most of us would be familiar. Sometime or the other we would have read it in some journal article. Okay, next question. Suppose I'm dealing with 2 groups, but my outcome is a numerical variable, and I want to see whether the distributions are similar or they're different. So supposing I'm comparing a dopamine group versus a dobutamine group, my outcome variable is numerical. For example, urine output. So urine output is numerical because it is so many ml per kg per hour. At least in unitologists always talk about things in per kg per hour. I don't know, adults would probably be just referring to it as ml per hour. So anyway, it's a number, ml per hour. So question is the distribution of the numerical variable? First question I asked myself, is it skewed in either group or is it normally distributed in both the groups? Because whenever there's a numerical variable, first question you ask is it skewed or is it normally distributed? So if it is skewed in either one or both the groups, I mean dopamine, dobutamine, so basically I'm comparing the median and the quartile ranges in the two groups. That's what my table is going to look like. I use what is known as the Mann-Whitney U test. So the Mann-Whitney U test is used two-group comparison, numerical outcome, at least one or both the groups that numerical outcome has a skewed distribution. If on the other hand, it has a normal distribution in both, so then my table is going to look like this, dopamine versus dobutamine. It's basically the mean and standard deviation that I'm comparing, and that is your familiar student's t-test. When you just say student's t-test unqualified, you're implying it's an unpaired student's t-test. So the Mann-Whitney U test is the equivalent of the student's t-test if the distribution happens to be skewed in any one of the two groups. Now I said it is two or more groups. No? So till now we have dealt with only two groups. But what if the comparison is between three or more groups? So there are equivalents for each of these tests. So supposing, let's start off with a binary outcome, the percentage of responders. And supposing the trial that we have done is drug A versus drug B versus placebo. I mean, so there are three arms to the trial. Then the test to be used is same chi-square test. There is no difference. It just becomes instead of a 2x2 table, it becomes a 3x2 table. And you still use a chi-square test. So the equivalent test, had there been only two groups, would have still been chi-square test or a Fisher's exact test. For 3x2 or 4x2, etc. Tables, at least in SPSS and certain programs, you don't have a Fisher's exact test available for that kind of a thing. But theoretically, a Fisher's exact test can also be done for 3x2 tables. But by and large, it's acceptable to just do a chi-square test for more than 2x2 tables. Let's take the second example. So three-group comparison, outcome numerical, and it is skewed in at least one or more of these groups, say urine output. And suppose, for example, let's say we are doing a trial comparing dopamine versus dobutamine versus adrenaline. So there are three arms in this trial. Outcome is, say, urine output. Then the test to be used is called the Kruskal-Wallis Test. The equivalent, had it been only two groups, would have been the Mann-Whitney U test, which I told about earlier. But now it is called the Kruskal-Wallis Test, three-group comparison. If the outcome is a numerical and it's normally distributed, say it's mean blood pressure in three arms, again say it's dopamine, dobutamine, adrenaline, then you use a test called the analysis of variance, which is shortened to ANOVA. I think a lot of us would have encountered this term ANOVA. The equivalent test, had it been only two groups, would have been your familiar student's t-test. So when it's three or more groups, it becomes ANOVA. Interestingly, when either of these tests are used for two groups, you get the same result as you would have had you used the two-group test. So if, say, by error you use the ANOVA in a two-group situation, you will get the same result as you would have got for a student's t-test. Okay. Now, what are related groups? This is an important concept. So related groups occur in two important situations. One is a single group which has provided two data sets to you. For example, studies which are designed as before and after studies. Same patient, something data is taken before, you do something and then you take the data on the same variable again, all over again. So this is paired data on the same subject. So all of these are considered to be related data sets. Or it could be two similar organs from the same subject. At least in neonatology, we face this situation very often. So one eye with retinopathy of prematurity treated by one modality, say laser, the other eye either not treated or treated with some other modality, like say intravitreal injection of anti-VEGF, etc. So wherever there are two organs which are both affected, you can have trials designed as one of them is getting one treatment, the other is getting another treatment. So then the data that you're getting from the right eye and the left eye, or one treatment versus another treatment is considered to be related. Or you could have two groups where the investigator has voluntarily selected the subjects such as the controls are matched with the cases for certain characteristics. Then again they become related groups. Again, very common in clinical, in research practice. So matched cohort studies, matched case control studies, etc., all fall in this group where the investigator is specifically matching for something. Just a warning, randomized control trials don't fall in this group, because randomized control trials, the similarity between the two groups is occurring by a random phenomenon. You are not voluntarily matching up the subjects for certain characteristics. So you don't use, they are not considered related groups if it's a randomized control trial. And finally, subjects which are matched by virtue of biology. For example, twins. Again, in pediatrics, such examples abound. So twins in which one of the pair of twins is allocated to one group, the other is allocated to another group, and that's how the whole study is designed. So what if the comparisons between the two are comparisons are between two related groups? Then the tests that you use are different than the usual tests, and it's important to know that. If the outcome variable is binary, example, the proportion where retinopathy of prematurity has remitted, that's your outcome, remitted or not remitted. For example, eyes of ROP patients randomized to two different treatments. So for each patient, it's like a coin toss, whether the right eye is going to get treatment A and the left eye treatment B, or vice versa. So that's how the eyes are getting allocated. The test to be used is called the Mcnamara test. Again, named after a statistician, Mcnamar. Just to refresh your memory, the equivalent test, had they been unrelated, would have been the chi-square test or the Fisher's exact test, which we have already talked about. Next example, suppose you're dealing not with a binary outcome, but with a numerical outcome, and it happens to be skewed. Say the peak expiratory flow rate in asthma patients, and suppose the trial is designed as a before and after bronchodilator kind of a study. So you have one data set from the same group of subjects before you gave a bronchodilator, and again you measure it after you gave a bronchodilator. So each subject you're getting a before and after paired data. Then you use the Wilcoxon signed rank test, as opposed to the Mann-Whitney test, which you would have used had it not been paired or related data. And finally, if your outcome is a numerical outcome and it's normally distributed, say blood pressure, normally distributed in patients, say before and after an antihypertensive, then you use the paired students t-test. Otherwise, you would have used just the unpaired or unqualified students t-test. Okay. Now I'm just going to run through, of course, we don't have much time. We have to finish before 2 o'clock. So run through a few simple quizzes, and I would urge all the students in the audience to try and attempt them. So although there are a lot of named tests, it's not actually so difficult when you try to get to it. Okay, so supposing quiz, and these are all unfortunately neonatal examples. They're not obstetric or gynecological examples. So I measured the gestation of, say, 72 neonates. So there are 72 neonates out here, and at the bottom are the gestational ages, and someone tells me that the mean and standard deviation is 31.6. P-value, which you can see, is more than 0.05. So what's your guess? Do you think this data is normally distributed or is it skewed? Normally distributed. And can you just shout out why do you think is normally distributed? Sorry? The median is close to the mean. The standard deviation is really small compared to the mean. So it's not, the standard deviation is not more than half of the mean. This p-value of this test is non-significant, so n is equal to n, so non-significant, is not skewed. There's just a little aberration here. One thing which seems to be going in a different direction, the skewness is more than double the standard error of skewness. So sometimes you may happen, which suggests that it could be skewed. So sometimes you may happen that you look at the data in multiple ways, and they seem to sometimes not all go in the same direction. So a little bit of a value judgment is sometimes required as to whether you're going to call it skewed or not skewed. This diagram seems to suggest it's skewed. It looks pretty much bell-shaped. So I think overall we would conclude that, yeah, it looks as though it's normally distributed rather than skewed, because there's just one thing, that parameter, that's going haywire. Okay. All right, so second quiz. So in a randomized controlled trial, mothers with preterm labor receive tocolytics. So they're getting randomized to two arms, either to receive magnesium sulfate or a calcium channel blocker. And our outcome is the duration until delivery in, say, hours. How many hours did it take for delivery? You're trying to postpone delivery as far as possible. So the magnesium group, this is the mean and standard deviation, 40 hours plus or minus 23 hours. The median is 58 hours. Kolmogorov-Smirnov test p-value is this. In the calcium channel blocker group, the median standard deviation is 48 plus or minus 5 hours, median 46. This is the p-value. So how do we go about this? So the question is, of course, what test should I use? But if you're going to go about it systematically, first question you ask yourself, what am I dealing with? Am I dealing with a single group of subjects, or am I dealing with two groups whom I'm comparing? Two groups which we are comparing. So we all agree on that, right? Okay. So if I'm comparing two groups, is my outcome categorical, it's binary, or is it numerical? That means it's a number. Numerical, because it's the number of hours that I'm interested in. Okay. So if it's numerical, I therefore need to know whether it's normally distributed or it's skewed. So what is my guess? In the first group, magnesium group, is it skewed? Okay, why do you say it's skewed? Yeah, so these are rules of thumb, remember, huh? I mean, you could go wrong. Like all rules of thumb, they have their own limitations. So yeah, the standard deviation looks pretty big. It's more than half the mean. What else? Yeah, your judgment is that the median looks like it's pretty far away from the mean. The p-value is significant, so S is equal to S, so you know it is skewed. What about the second group? Okay, for reasons which we've already discussed, it looks normally distributed. Okay, so at least one of them is skewed. So if at least one of them is skewed, am I dealing with two groups? Outcome is numerical. At least one of them is skewed. So what test should I use? Yeah, the Whitney U Test. You're absolutely right. So the Whitney U Test. And had they both had normal distributions, what test would I have used? Not chi-square is when the outcome is binary. The unpaired student's t-test. So the student's t-test is these two are equivalent tests. The Whitney used when it is skewed, the student's t-test when it is normally distributed. Okay. So third quiz, we have 100 pairs of premature twins. So there are pairs of twins randomly received to get vitamin A or placebo soon after birth. The hypothesis was that vitamin A has wide-ranging effects on the immune system and blah blah, epithelial integrity, so it decreases mortality overall. So one in each pair of twins gets vitamin A, the other got placebo. The outcome was mortality by 6 months of corrected age. Okay, so the question is, what test should I use? So again, let's go over it systematically. So what am I dealing with? Am I dealing with a single group of subjects, or are there two groups that I'm comparing? Two groups. Okay, so the two groups I'm comparing are the vitamin A group and the placebo group. So each kid in the vitamin A group has a corresponding kid in the placebo group because they're twins who are getting allocated. Okay. So two group comparison. The outcome, is it numerical or is it binary? It's binary. So it's mortality. So did they die or did not die? As opposed to say number of hours or number of days or weight or height or whatever. So binary. Are the two groups related or are they unrelated to each other? Related. Why do you think they're related? Related by biology, right? I mean, they're twins, so they're going to have some genetic similarity. Even if they are dizygotic twins, there's still some, genetic similarity between kids in one group versus the kids in the other group. Okay. So therefore, what test do I use? Two group comparison, binary outcome, and they are related. So yeah, it's something related. It's not really the chi-square, because chi-square you use where they are the two groups are unrelated to each other. I mean, they're not really twins, they're just randomly allocated. But here they're not. There's a relationship, a biological relationship. So there is a test which is similar to the chi-square test called the Mcnamara test. You may have forgotten it. It had come in one of the previous slides. So the Mcnamara test is what really needs to be used in this study, because it is not just a chi-square situation like, any kind of kid getting randomized to receiving vitamin A or placebo. Here the two groups are related, although they are randomly allocated, because every kid in the vitamin A group has a corresponding, a biologically related kid in the placebo arm. So therefore, you need to use what is known as a Mcnamara's test instead of the chi-square test. Next quiz. There are 1,200 males who had total cholesterol measured at 40 years of age. They were followed up for 10 years without any intervention, just observing them. 250 developed coronary artery disease. In the coronary artery disease group, the mean SD cholesterol was what is mentioned here. The median was this. This was the skewness, standard error of skewness. In the non-coronary artery disease group, this was the mean cholesterol and standard deviation. Median was this. The skewness was this. Standard error of skewness was this. So the question is, what test will you use to compare the cholesterol between the coronary artery disease group and the non-coronary artery disease group? So again, let's go over it systematically. So am I dealing with just a single group of patients or two groups? Two groups. Okay. The two groups are coronary artery disease and non-coronary artery disease. In them, what is the outcome or what is the variable of interest that I'm measuring? It's cholesterol. Okay. So cholesterol, is it binary or is it a numerical variable? It's a numerical variable being expressed as milligrams per deciliter. Okay. So now my decision I have to take is, if it's numerical, whether it is skewed or not skewed. So not skewed. I'm not going to go over that whole list of things again. So it looks not skewed. The means are fairly close to the medians. The standard deviations are small. The skewness is pretty small compared to the standard error of skewness. So it's normally distributed in both the groups. So it's a two-group comparison. It's a numerical outcome where it's normally distributed in both the groups. So what test do I use? So it's a numerical variable. No. It's a numerical variable. Are these two related groups? These are 1,200 males. You've just picked them up. They're not. I didn't say twins. Twin males. One of you're comparing. So nothing like that. So these are just 1,200 males you've picked up. They've come to your OPD. None of them even knew each other. So it's the unpaired, it's a standard unpaired students t-test. So two groups, a numerical outcome, normally distributed. This is your, the vanilla equivalent of statistical test. This is the usual students t-test that you keep seeing and reading about. Okay. This is the last one because I've overshot by a few minutes. So among patients with sepsis, quantitative CRP, that means CRP expressed as milligrams per deciliter, and quantitative procalcitonin were performed. Procalcitonin also being expressed as something per deciliter. And the mean standard deviation of the CRP is given here. I have not provided the one for procalcitonin, and this is the statistical test p-value. The aim is to find whether an increase in procalcitonin corresponds to an increase in CRP. That means every time procalcitonin goes up, does CRP also go up? Okay, so what test should I use? So first question, am I dealing with a single group of patients or are there two groups of patients? Single group, yeah, that's good. This is the most important thing. First, to realize whether you're dealing with a single group or two groups. So first hurdle crossed. So it's a single group of patients. So in every patient, I'm measuring both CRP and procalcitonin. And I am just interested I'm not interested in knowing whether those two numbers agree. Obviously, they will not agree. Procalcitonin and CRP are two completely different things. There's no question of any agreement out here. I'm just interested in knowing if as one of them increases, does the other one also correspondingly increase? So these are what I told in one of the earlier slides. These are test where you're trying to find out a coefficient of correlation. Okay. Now I've provided only one of the for only one of the variables information, CRP, which clearly looks as though it is skewed, right? Because it's got a huge standard deviation. The p-value of the KS test is significant. S is equal to S, so significant is skewed. So it is skewed. So it doesn't matter what procalcitonin is. Procalcitonin may be skewed. It may be normal. It doesn't matter now, because the fate of the test is already sealed because one of them is skewed. So this we will be using what is known as the Spearman's, some of you got it, the Spearman's coefficient of correlation, as opposed to the Pearson's coefficient of correlation, which we would have used had they both been normally distributed. Okay, so with that I'm going to end here. This is just a teaser towards for statistical tests. There are a wide range of tests for all kinds of situations. The important thing for you to know is that there are different tests for different situations. Because often one finds in protocols of thesis, the students write, we will use the student's t-test and the chi-square test in this study. Now, you don't know what your data is going to turn out to be, So there could be various scenarios which you will have to cater for when you are writing the statistical analysis plan, that for wherever we are doing, say, 2 group comparisons, this is what we're going to do. If there are 3 groups, this is what we're going to do. If it turns out, if the numerical value turns out to be normally distributed, this is the test we're going to do, and so on and so forth. And just bear in mind that there are different tests for different situations. So don't just blindly go by the chi-square and student's t-test, which are the most popular and most commonly used tests. Okay, with that I thank all of you, and I'll take a few questions if there's any time.
Thank you, Dr. Saurabh. It was excellent talk, and you have really simplified it and very interesting. And one thing I want to tell about Dr. Saurabh, which Narayanan hasn't told, he's a very good story writer. He is very witty and has great sense of humor.
There were no stories today. This is all factual. Okay.
But these are actual, yeah. You have really ignited that, interest in students, I'm sure, no?
Okay, thank you, ma'am. Oh, okay, it's like that? Fine. I'll wait till the... No, it's not...
Yes.
The type of tests that we use are being determined according to what you have said, is based on the type of the nature of the data that we generate in the test, in the trial. There are other indications for using different types of tests based on the theoretical way that the data is, like whether it is ordinal data or numerical data. I think you should just say something about that so that they will know something. A priori, some types of data will have to be analyzed in a certain way.
Yeah, I mean, I didn't go into that because that would have made it more complex for an audience like this. But for instance, those, suppose you're dealing with 3 or more groups of patients and you're measuring certain outcomes in them. Those 3 or more groups, so that's basically categorical, right? So the grouping variable is categorical in the sense that patients are being categorized to certain groups of patients, so it's categorical. Now those groups may either be in a logical order or those groups may not be in a logical order. If they are in a logical order, that grouping sequence, then that grouping variable becomes an ordinal variable. As opposed to the grouping variable being a nominal variable. That means there's no particular order to it. If there is a particular order to those groups, okay, then there is a different related kind of test used, for those situations. Let me give you an example. Say the grouping variable is NYHA class. You're all familiar with NYHA classification of cardiac patients, right? So NYHA classification is an ordinal variable because there is a certain logical order to NYHA class 1, 2, 3, 4. So they are not exactly proportionate to each other. So I cannot say that 4 is exactly twice as bad as 2, but so the interval between them is not a fixed thing, but they are in a logical order. And supposing my outcome is, say, a mortality comparison between NYHA class 1, 2, and 3. Then I cannot use just my regular chi-square test because there is a certain order to the results. So to capture that, we use something called a chi-square for linear trends. And there are several other tests also available, but chi-square for linear trends is a common way of trying to capture the linear trend that you expect between ordered groups. If you use, if your outcome is a numerical variable, some number between these 3 groups which are ordered, and the numerical variable happens to be normally distributed in all the 3 groups, then there's an equivalent of ANOVA. ANOVA would what you would have used otherwise, right? Numerical 3 groups. Then there's an ANOVA for linear trends which is available, and certain other tests are also available to capture this linear relationship. If it is a skewed distribution in any of them, then there's one very peculiar test called the Jonquieri-Terpstra test. I don't want to, it's Jonquieri test is the skewed equivalent of this ANOVA for linear trends, where your 3 groups are in a certain logical order. So like this, there are a whole lot of tests for very specific situations. So I think I'll leave it at that.
I think, sir, they are already quite confused.
Yeah, because they are unfortunately they're all named tests, after a person who described it, and that sometimes makes it tough.
The more important point here is to remember that there is an order. If there's an order, that statistical tests are different, then you can always consult your statistician.
You can always, or consult somebody or read it up,
or Google it up.
Right.
So there are 2 questions. Both of them are out of syllabus, unfortunately, but still. So how can we deal with outliers and inliers effectively? That is the question. How can we deal with outliers effectively?
I mean, it's a rather broad question, so I'm not sure in what context.
That's why I said it's out of syllabus. So we'll take it up. You can take it up one-to-one after the workshop. The second one is a little more this one. Should missing data be handled by the researcher at the end of the study? Just an overview, brief point on that.
Yeah. So it's not a good idea to simply drop the missing data. I mean, that's the worst possible option that you have, because they may be missing for a reason. And if they are systematically missing for a reason, then your estimates are going to be very biased if you're just going to drop all the missing data. Again, how to handle missing data is a whole lecture by itself. So multiple imputation is what most people would use to replace missing data by the most biologically plausible value for that missing data. But there are people who use more cruder methods like the last observation carried forward, or the mean of the whole group imputed into it, or the median of the whole group into it. All of them have problems with them. So I'll leave it at that. Yeah. Okay, thank you.
Thank you, sir. I think the easier part is that the module is available in SPSS, so you just have to click. It's as simple as that. Okay. You have written syntax and everything for that, so it's not very hard. But remember the principle. The principle is what is more important there.
Do I need to wait for the next talk?
No, sir.
Okay, thank you. Thanks a lot.
Yeah. Now, it's my privilege to introduce Dr. Sonu Goel, who's professor in the Department of Community Medicine and School of Public Health. He has 18 years of experience, young professor, and he's a recipient of various awards in research and in academics. He's a good orator, and his main area is tobacco control. And he's an honorary professor for many European universities also. Dr. Sonu, please. He'll be speaking on, very important for faculty, how to publish studies, even for students. After you do your thesis, how to publish.
Thank you, ma'am. So I think I'll start my talk with a few caveats because it's a 35 minutes talk and I may not be giving justice to writing papers in this 35 minutes. And second caveat is I'm not a very, I have not published that much number of articles as some of the people in this audience, including the chairs. I can see the number of publications and chairs. So I hope that they will add to my talk after this short, brief talk, which will be talking about the pointers. I will not be talking about the details of what you need to consider, but just few pointers, what you should consider when you will be writing the article, when you have thought of writing the articles. So I think this is actually the topic, which is what editors want. So that is what keep us guessing that what actually editors want. Every time we face a rejection, what do you want? And today I face rejection from two of my manuscripts, so that's a hard day for me. And similarly, I think the same type of feeling you might be having when you're publishing. I can see young, I think, faculty and the residents here. So the same type of feeling which we used to feel, same you might be feeling when you face a rejection. So I acknowledge, because I am a part of operational research team of International Union, which conducts few courses on this. So I want to acknowledge few people here, Tony Reed, Ajay Kumar, Anthony Harris, and J. Prasad Tripathi. So is it moving from here? Okay, I'll do it from here. So why we should publish? I think that's really simple. The first one is this one. Rather than, I think this is one, yeah, ethical and moral obligations for sharing the results which you have found. Definitely, whatever you have found in your clinical settings, it's your moral responsibility to actually share. Otherwise, people will not know about what actually happened. So that is the first thing. But yes, this is very important because now some of you might be appearing for faculty. So your CV, the first thing which people ask is how many papers? How many papers? So that is one thing which is really important. It's the best way of disseminating the knowledge. And the fourth important point is, like, we want to change some policy decisions. Like there are some policy decisions which happen, no, in your area also in OBG. So I think, again, in every area you have a policy decisions. So when you publish your paper, so that policy decision keep on changing when you do a research. And then don't contribute to publication bias. Like if you are not publishing and somebody else is publishing with different findings, so what will happen? So there is a bias. There's a, I think the last session you heard about skewness. So it's also a skewness, no? If you are not publishing your finding and the reverse findings are there from some other one, so I think there is a skewness in the publication. So that is the broad reasons why you should publish. I think someone of you might have heard about this Moses's hand. So what was it? So everyone, including God, has to deal with the editor. So basically, it's the editor has a major job, and Moss, I think the 10 Commandments, which you have heard about. So he was the person who has actually not criticized, but actually wrote his own books, 5 books he has written. And every time he has to explain what these 10 commandments actually meant for in a different languages. So this was one of the, I think the job which was done by Moshe, somebody like Moses or Moshe people used to call. So that is the importance of actually the editor. So golden rules now. Now here, I think you can note down some of the points or you can memorize those points. The first thing which we don't do ever, I have not done till 5 years back, is I wrote the article and then choose the journal. So we should do reverse. We should first, whenever we have started thinking about publishing an article, you should start looking at the journal. I'll tell you in the next slide how to choose a journal. But first thing first is choose a journal before you start publishing. This is the golden rule, number 1. The second thing, we never see these guidelines, author's guidelines in it. And I think I can bet that nobody prints those guidelines in this era. But I always, for young researchers especially, print those guidelines in front of you. It not only keep you motivating, but whenever you are writing those articles, you can have a check and balances. You can see what I'm not writing, what is not required, and what is required. So these are the two things which are really required when you're started writing an article or thinking for a manuscript, and rigorously, religiously follow them. So these are the first golden rules. Now, how to choose a right journal? These are some of the things, but I think my colleagues here might suggest few more things which are really required. The first thing is your audience. Where you want to direct your findings. Like for example, for your direction of finding is like OBG audience. So mainly, but some of your findings might be global audience. Like for example, I'm just taking example is like tobacco control related to maybe some adverse event in the OBC. Any adverse event you can think of. Okay, so here your global audience might not only be the people who are actually in your discipline, but they can be people in general because they are looking after the global tobacco control or a tobacco control journal. So first of all, you need to be very clear whether it is a generic audience or whether it's a very specific audience, because that will, when you are writing introduction and subsequent sections, that thing is really, really important. I'll be coming to the introduction section, like how these things are important. The second thing is like the interest of journals listed on PubMed. These are some of the things, like you should always consider that PubMed index journal is more important. I'm not saying the only important. If some journal has a higher visibility, sometimes you want to publish in a journal which has a higher visibility, but may not be PubMed index, then go ahead. It's not only the PubMed index journal which makes a sense. Sometimes a non-PubMed index journal, but you should be very careful about few predatory journals. I think there is an article you can read about in, I think NMGI or some other journal, that don't go with the predatory journals. Never. That will demolish your reputation. Because if you have given 2,000 rupees, 5,000 rupees and publishing in a predatory journal, so all those subsequent articles which you will be publishing will be of not much value, because people see that he or she has published in that predatory journals. Turnaround time is very important. We never see that. Turnaround time is like you publish an article, how quickly they publish the article or how quickly they give the first response. That is also written in some of the journals. When you see the journal site, they have written the turnaround time is around this much weeks. That is again important, because if the turnaround time is very long, like if it is 3 months or 4 months, then I think it's better to publish in a journal which has a lesser turnaround time. Then open access versus closed. Open access journals are really important, because that will give, open access means like when you publish those in those journals, that will be, anybody can see that. Closed access means like when you are publishing, only those people who have that access to that journal can see that. So open access are good because many people can see that. But the only policy in open access is the charges. Some charge too high for anybody of us. Then if you are not sure about it, ask a seasoned colleague that what are the other ways we can choose a right journal. So that is really important, to choose a right journal, because this is the start. Now, these are some of the things which you can check, because when you are, why I have told that you should see the journal first. Because if you are publishing a short report, and if that journal is not publishing a short report, then again your all mehnat, every effort which you are doing will go waste. So that is why when you're choosing a journal, you'll see what are the sections in which I'll be publishing, and then you can select that whether I'll be doing an original research or a short report or any other type of manuscript. Now, I think this is, everybody might be knowing IMRAD. In last lecture also, we have been talking about these guidelines. So why I am emphasizing upon it is, Because what happens, you're doing very good research, very good methods, but when you're not writing properly, so what will happen is the editor will not know that whether you have really done that rigorous research. It is your, I think doing a research is equally important as communicating the result. So whenever you're writing some, like if it is a cross-sectional study, always keep on having a strobe guidelines or the guidelines which are really important for that type of study. Keep that in with you. And you can have a checklist, whether I have done this, done this, done this. So it will give an idea that all the important components of that type of study is included in my paper. Right? So you have chosen a journal, you have printed their guidelines, and then you have printed the format like this STRAD, Consort, Prisma, Strobe, or the guideline relevant to the type of the study which you have performed. Right? So these are the three things which you have done. So this is a IMRAD format. I think almost every journal, bearing few, is using this type of, you have introduction, method, result, discussion. So some people include conclusion at the end, or some people include conclusion in the discussion section as well. Now, this is just an article that I'll be telling you about how to write a background. What are the things which are really important for writing a different type of sections? So I think introduction, that is one of the most important thing, because when somebody is reading the introduction, they should get a point that what is known and what is unknown. Two things, what is known, what is unknown. And before that, the problem statement. So actually what I guide a researcher or the MD student who comes to me, क्या लिखना है इंट्रोडक्शन में, उनसे बोले 3 पैराग्राफ is very important. The first is the problem statement that should incite the editor to take that study. That is really important. When I used to write the tobacco, so tobacco is the leading cause of mortality. So it's really important to publish some article related to it. So then I give some quantific figures, like how many dailies are lost, how many mortality, what is the morbidity. So initial few lines, 5-6 lines is only this. But you should be very careful when the journal is the tobacco control. So if everybody writes these lines, then nobody will, the editor will not take your. So you have to, in a specific journal which is related to your specialty, you may not write the generic issue, but the specific issue initially, you can start with a specific issue which you will be talking about. So for a specific type of journal, jump to a specific question or issue, or when you're writing in a generic article, setting the scene, what is the problem, and then jumping to the specific sections, what has been done before. That is important, because they want to know that what has been done. Are you not repeating? Are you not repeating the findings? Right? So they want to know what has been done before. So people usually cite a lot. Like I find sometimes 20-25 references in the introduction section. So I think that is one of the things which I say, but don't undercite as well. Then what are the problems with the previous research? So what are the gaps? And then what is new? So that is very important. So you have to market your research. You have to market your research. Market your research means you have to clearly say that these are the things why I have done this research, which very few people have done, or people have done, but in Western countries, not in India, or some sort of unique thing which you are actually doing in this research. So 3 paragraphs. One is problem statement. Second paragraph is what is known. Third paragraph is what is unknown. So I think this is how, and then you conclude with the objectives. And I'll tell you what. So this is just an I think how the introduction can be written. Like if it is a something related to non-communicable diseases, the previous article which I have told. So NCD accounts for 72% of all deaths in 2016. So that is important, 72%. Some people say majority of the deaths. So it is better to write the figures. So that is that is important, with 3/4 of all deaths occurring in low and middle income countries. So that is again setting a scene because you are doing a research in low and middle income countries, so you should write that. So in the first 2 sentences, you have built a scene. Then you have jumped to the topic to curb this rising epidemic in low and middle income countries. The WHO developed a package for this. Huh? So this is what was developed. But what has been done? There has been little global evidence about the implementation and effectiveness of this package. Package has been developed, but we are not knowing about this, right? So this is what has been done before, and the gaps are here. And then some people write the context of the country here, like Myanmar is experiencing a rapidly evolving epidemiological transition marked by an increase in NCD burden. So why we are doing in India? Why we are doing in Myanmar? So this is how, like you are telling in the last paragraph of that introduction, why I am doing the study. So this is how you need to frame your introduction. So introduction should not be normally, I think again a thumb rule, not normally more than 5 paragraphs, 5 or 6 paragraphs, but it depends. Plus, I think takes for like n number of words, there is no limits. But 5 paragraphs, 4 paragraphs is good enough for an introduction. And then jump to the topic again. To tackle this growing threats, Myanmar adopted these guidelines, and there has been no evaluation of this project in Myanmar, and that is what we are doing this. Right? So, looks simple, but when you're writing introduction, you have to rewrite, seeing all these things, whether I have done the paragraph like this, then methods. I think it's separate lectures, a beautiful lecture, last lecture by Dr. Saurabh about statistical analysis, which is very important, but these are some of the common heads under which you write methods. There can be some heads which we can add upon, but these are, I think, design, settings, study population, data collection, variables. I think many of you might have written these articles, so nothing new in it. But what is new is that how do you write this? So study design, I think you can write which type of study design you are using, always necessary. Again, this will come in that guidelines also, Strobe, Consort, all these guidelines. So which type of design? Then settings, divide that setting into 2. Normally, like one is general settings about your country. If you are publishing in an international journal, write about that setting in a country, like what type of country in relation to the problem. And then about the specific setting, like that project was talking about WHO PEN project. Nobody knows what is WHO PEN. So you need to describe that settings for an international audience. What type of project I am evaluating. Okay, so you need to write that. Then study period and sample size and so on and so forth. So I think I'll not. So then comes results. So some people we have been evaluating is they write many more things besides the findings in the results. So it is just the facts. Whatever you have found in the study, only mention that, nothing else. And always, sometime what we did is, like what we found, that the objectives are something different and the results are something different. So always match the objective with the results, whether my results are in line with the objectives. Go back to the objective, write the objective in front of you, and then see whether the results are actually matching the objectives. Write the response rate in the initial part of the result. That's a very good practice, that whatever 100% response rate, I think last question was there. So what was the response rate? How many people actually responded to your questionnaire? So it was 92% or whatever. Then initial thing is about demographics normally, like one initial table normally people, if there are not too much tables, the first table normally in 70% of the paper is demographic characteristics. So write that demographics, but the only problem, what people do is, they write exactly the same thing which is there in the table. Don't do much, like only write 3 lines maximum. Rest are there in the table. Key significant findings in the demographics, Then outcomes in numbers, p-value, confidence interval. I think Dr. Saurabh has told about it. Avoid duplication in text and tables. Tables and figures should stand alone. What is stand alone means? Like somebody who has not seen the text might be able to interpret the table. So normally the titles are sometimes very small. So the title should be self-explanatory. The tables, all the things should be, even you don't have to go to the text to interpret the table, right? And stats only report the planned outcome, again based on the objectives. Discussion is the most difficult part, which normally people struggle. How to write the discussion. So again, it is really a difficult thing, but normally we structure like this, but it can be other way around. Some people write strengths towards the end of the lesson. So normally what I do is like initial paragraph is about the key findings, what we found that in the study, what is new. So always reflect upon something new, which is there in the first paragraph. The second paragraph, normally I write strength, but you can always put the strengths towards the end. So strengths are first, this study being the first type of study. But again, when you're writing the first study, we have a very good habit of writing that this is the first study of the country or first study from this region. Always be very cautious when you're writing the first study. Okay, so this is the thing. Compare with literature. Always don't write the results as it is. When you're writing the next paragraph, so what I used to tell my, again, MDs, that select 4 or 5 key findings from the study. What are the main thing which was there? Put separately, then discuss one by one. Discuss means write about that, what you have found, what other studies have found, whether they are contrarily or similar to your findings, and then give an interpretation. Don't leave as it is. Don't leave without comparing or without giving an interpretation. Why you have found that? Why it is different from other settings? Then you keep on writing second paragraph, second main result, third, and so on. Right. So I think then towards the end, you should write what are the implications and future research questions, like what is emerging, what are the limitations, very important, like what are the main limitations of this research. Again, 1, 2, 3, first, second, third, you should write that. Conclusion. So keep it short and simple. Conclusion, normally some people write only 2 lines. Again, that is not desirable. Conclusion should be 4, 5 or 6 lines, including the recommendations. So what are the very important key things which you have observed from the policy point of view? From the policy perspective perspective. So again, what did it show must be supported by the data. Sometimes what happens, some people write conclusion, but that was not the finding of the study. That is not your conclusion. Conclusion is about your paper, about your results. So write only that conclusion and relate back to your objective. Again, very important. Always keep on going back and forth. So I think this is an example of the discussion. Again, you can see like this assessment they have done. This is the objective they have written. This assessment of this in 20 township yielded some interesting finding. The 6 key finding of the study are this. So first, second, third, and this is how they have given the finding in the first paragraph. Then the study has some strengths, again that paragraph. Again, like then you in between you can find what are the things which you have found and discuss, then few limitations and policy implications, and then conclusion. So conclusion should be somewhere like 6 or 7 lines. So what you find? This pilot project empowered non-physician primary healthcare worker to extend these type of services. These are challenges. So all these things you can, maybe you can take this presentation. I think that presentation can be shared with you. So it is basically telling a story. As I think I was, those who are very fond of telling a story write very good papers. I have found that. So because paper is a story, you need to convey in a story way, but scientifically strong, to your audience. So it's like telling a very simple story, very clear. I think these are some of the other rules which may not, like jargon should be minimized and keep sentence simple. Some people think that if I make very strong, complicated sentences, join multiple sentences, the editor will be very happy. No. So I think 15 to 20 words, these are keep paragraph short, like 5 to 6 sentences, or I can say like 10 lines or 12 lines at the max for a paragraph. And keep on reading back again that whether some words are redundant. If some words are redundant, remove them. Again, writing can be active or passive. Active means sometimes we did a study. Some journals, many journals in fact, do not like that active voice. People like passive voice, but some people have a habit of writing in an active voice. Again, see the journal guidelines, otherwise use passive voice. I use it. So avoid abstract nominal. So these are some of the things I think I'll not discuss because there are few things which are really important, which, this is very important. You know a lot. I think you are very good researcher. You have done very wonderful work but how do the editor know whether you have done that good work? It is by your impeccable writing skills. This is another good thing which I always say, make a cohort of people, आपके दोस्त होंगे, अपनी result किसी और को दो, दूसरे का आप पढ़ो. This is how you keep on conveying that this is not, I have not understood this thing. So you can critique each other things in a group. Go to multiple drafts. Some people say, चलो submit कर देते हैं, देखते हैं editor के comment आएंगे, फिर उसके हिसाब से हम review कर लेंगे. No. You should be very clear that whatever I have presented is very clear to me and my colleagues. तभी आप जाके सबमिट करिए, अदरवाइज डोंट रिलाई ऑन, बिकॉज उसमें आपका टाइम वेस्ट होगा. अगर आप भेजेंगे तो 6 वीक्स बाद उनका रिस्पॉन्स आएगा कि नॉट हैप्पी. ओके. Plagiarism, very important, because now I have seen many journals, they run the plagiarism check before actually editing it. So always run the plag check before you submit. So I think you might be having the software for it. Plag check. Tone is very important. I have said that don't overstate the importance of the finding, that this is the first finding which I have found. First time in the country. Don't overstate it. These are some of the bits and pieces, because this is what the main structure of the article. Bits and pieces are titles and other things. So just quickly, I think this is very important, that title is the first chance to catch readers' interest. I'll be finishing in next, I think 5 minutes. So this is very important, because the first thing which your editor see is your title, how catchy it is. But it is tried to hook them, and it is really important that it markets you. Okay, so always try to keep the study design into it. Some people prefer that study design should be inbuilt into this. I think these are some of the titles which can be either in a question mark. Some people put the title as a question. Like for example this, will adoption of 2010 WHO ART guidelines for HIV infected TB patients increases the demand for ART services in India? So the answer of the question lies in the article. Okay, so this keeps interesting, keeps on guessing, yes or no. Okay, so this is a good way. And this is again a question, can follow-up examination of TB patient be simplified? Okay, this is a statement. This is question, these are statement. High diabetes prevalence among TB cases in Kerala. So again, you can give either as a statement or as a question, your title. And here again, there are some interesting way of putting this, I think, title page, I'll not go. These are some of the common things which you will find in the journal's guidelines. The abstract is the second important thing after the title, which is really important, because then the editor will see how the abstract will look like. So that should be, although it is the first part of your manuscript, but it should be designed towards the end. When you've written everything, Don't write abstract first. Abstract should be towards the end. It can be structured or unstructured. Structured means like these are IMRAD format. First write 3 lines of introduction. Some people what they write in IMRAD, in the abstract, they write more introduction, but less methods. No, always write less introduction. Maybe they can directly start with the objective. Some people write only objective in the I. But more should be methods comparatively. If you have a 250 words or 300 words abstract, always try that 100 words should be devoted, 80 to 100 words should be devoted to the methods part. So again, most people only read this. They will only, not only the editors, but when it is published, the first thing which readers do is read the title, read the abstract. If it is catchy, then they go to the article. So I think these are some of the other things which are really required: acknowledgements, funding, conflicts of interest, author's contribution, referencing. So that is most important thing. Most important thing. I have told that today my 2 articles were rejected. Yes, these are part and parcel of life. So do not expect the paper got accepted right away. Right away. So again, all papers, there is the opportunity every time. Any paper can be improved upon. Any paper. Never say that this is the perfect paper. So keep on. Why this paper is rejected? And takes the comments. Take the what if you have received the comment, you should be very happy that at least I have received the comments and then the paper got rejected. And always work on those comments before submitting it to the other journal. Right? People say that journal has given the comments, but the second journal has not. But the reviewers might be thinking in the same way. Take revision seriously. Okay, so always be polite in making the comments. So I have normally make thank you for your comments. So it's a very thank you for pointing it out. So always start with that. So it's always give a very good feeling that you have really taken that thing very seriously. So perseverance is actually the key to success. If you are not, so always whenever this thing rejection comes, I have a cup of coffee or meet some friends, go for some quick somewhere I see a movie, and then I keep on thinking after that. So never be depressed after seeing a rejection. So who is the biggest enemy in getting your research published out of them? Some people criticize these person, editor. They have not even sent to the reviewers. Some people say reviewers, they have some false intention. They don't want my research to be published. They will publish their own research on the same topics. So no, neither your boss, neither your family. So basically it is perseverance, lack of perseverance. That is the main enemy. So it is basically writing. So always say writing is 90% procrastination. So this is usually happens, no? इसको रहने देते हैं और कुछ काम करते हैं, ये तो हम आराम से करेंगे, writing part. नहीं. So always start it. So that is the last slide. So read, pay attention, write, having something to say and logical thinking, talk about it before trying to write. So always keep on discuss. First keep on discuss with your colleagues, with your co-authors, what I am going to write, how I am going to write. Discuss that. Then accept that the writing is hard. Yes, we all accept that writing is very difficult. It's not your fault that you are procrastinating. It's not your fault anyway. So revise. Nobody gets the right for the first time. Because, you know, acceptance rate, 3%, 4%, 10%. So you are among that best 3-4% if that article is accepted. Okay. So you can always get better at writing or publishing with time. Over a period of time, you will learn that art. It's an art. It's an art to actually write. So, and this is what we do. We start something and then we are not, we don't put one of my previous bosses used to tell that everybody knows how to open a pen, but nobody knows how to close it. So we should learn how to close the pen, right? So I think thanks.
Thank you, Dr. Sonu. That was a brilliant presentation. Any questions?
Any question or any experience you can share, like?
I can tell you why.
Yes, sir. And you can add upon, sir, because I think these are very quick pointers. Which
I procrastinate because when I delay it, I become older, and by definition, I become wiser.
Doesn't happen with everyone, sir. Yes. Any question, anything which you fail to understand here, or?
You dread, na, you should start it, right?
Yes.
Then the fear goes off.
Yes. And if you start, you can keep on somebody, what happened to that article? Have you finished it? So start it and then try to finish in a time frame. मुश्किल है जो मैं बोल रहा हूँ ना, theoretically लगता है पर मुश्किल है. Thank you, sir. Thank you, everyone.
I would like to thank all the chairpersons for chairing this session. And now I would invite Dr. Ashima for the vote of thanks.
Thank you, sir. Thank you, ma'am. We'll just go on to the next workshop, which is online, so that has a separate link. We'll all join, and we'll be conducting it from the telemedicine department. We could not have had a better start for this 1.5 day CME. We have really learned, and I think we all are motivated to do some statistics and write better what we are actually doing the whole day. Thank you so much for coming, sir, Anand sir and Ritesh sir. Thank you, please, for joining us on a Saturday afternoon. Thank you, ma'am. Thank you. So the next workshop starts at 3. It is online. We all have the links.